morning, everyone. I hope everyone had an excellent time last night. Obviously, we did. We went up to Park City. If you haven't been, you've never had the opportunity to go, please take the time to go up. It's absolutely beautiful. It's even more beautiful in the snow. In the wintertime, it's just very picturesque, and you'll have a great time. So yesterday, a lot of good information, a lot of comments, questions, concerns got addressed, and we hope to continue with that today. Please, if you have concerns, you want some one-on-one time, please let Clay or I know. We're more than happy to meet with you, discuss any concerns or challenges you have. If you need us to do bidding with a vendor, or if a vendor needs us to do bidding with the state, we're happy to help broker that deal. As I say, we're more than interested in doing that. As Clay said, we do have 2 open positions. If you have questions about that, for the actual position itself, that's something that's hired through the University of Utah. That's absolutely Dr. Mann. If you have questions about how that relates to NHTSA and the contract, by all means, feel free to ask me. I'll be more than happy to provide you background from the Office of EMS perspective and from the NHTSA perspective on how we interact and work with the University of Utah. So with that, I want to introduce Dave Millstein from the U.S. Fire Administration. Dave is basically the NFIRS equivalent of me in NEMSIS. So Dave is leading up a lot of projects there, a lot of changes at the U.S. Fire Administration regarding EMS, and that's what he's going to talk with us about this morning. So Dave.
All right, good morning. I can't see slides. There we go. Okay, so I have a handful of notes, a bunch of things I'd like to discuss here this morning. So first of all, my background. I am Dave Millstein. I am the branch chief at the National Fire Data Center of the U.S. Fire Administration. I am also the interim branch chief for the EMS branch, also at the U.S. Fire Administration. My background is 20 plus years. Thank you. 20 plus years in the emergency. 20 plus years in the emergency services. Everything from a firefighter, paramedic, volunteer career. I retired in Frederick County, Maryland in 2018. And I've been in, I'm sorry. Okay. Been involved with fire data for most of my career. I walked into the fire department when I first joined, and they asked me a very simple question, which set my career in the direction it is today. Do you know Excel? So the answer was yes. And that started me into a position of looking at fire data and what fire data can be used for in the fire department. This was a volunteer fire department. So this department was about 1,200 calls a year, running BLS ambulances, hospital-based EMS, and they wanted to find out, well, what can we do with this information? We have all this data. What can we do with it? So we were failing ambulance calls pretty regularly. Everybody wanted to show up for the fire truck. I wanted nothing to do with EMS, truth be told. And I'm saying that here, all of you were protected, like you're between me and the exit. I didn't want anything to do with EMS. I was there to be in the fire department. Little did I know, the EMS side of the house was the predominant part of everything that I was going to be doing for the rest of my career. So the point there, with the fire department looking at a failing ambulance service, I was asked what can be done to fix the problem. So in looking at NEMSIS data through the state of Pennsylvania, NFIRS data, we determined that the fail rates were very specific, times of day, days of week. Everybody here can imagine Monday through Friday, between 8 and 4. Fail rate was near 100%, about 1,000 EMS calls a year. So using this data as essentially a brand new fire service, emergency services member, that was the kickstart to what is today 24-hour staffing with 2 EMS providers, both BLS and ALS trained. It took as everybody here could probably imagine, a long time to make that change, because there's a lot of reluctance to change, especially involving EMS with a fire-centric organization. Tail wagging the dog. So brings me here today, COVID. Thank you to the TAC, to Clay, to Eric. This is the first time I've had a chance to meet them. First time I've ever been here to meet many of you. The efforts through COVID saw us working with each other 16 hours a day, 7 days a week. And we realized that when we're asked some very simple questions, how many emergency incidents are there annually? How many response agencies are there across the United States, and how many responders? Does everybody in here think that those would be simple questions to answer? They should be about as basic as you can possibly get. We didn't have an answer. And that's a problem for a global pandemic that is negatively impacting the response agencies across the country. We didn't know how many people, we didn't know number of incidents, and we didn't know the number of agencies. That was a problem. So COVID was one of the big contributing factors to some of the collaborations that have occurred since then. A lot of them are being leveraged today to make the EMS branch at the USFA, which is in its sort of budding moments, as impactful and beneficial as possible to the EMS service in the country. So U.S. Fire Administration, prepared and resilient fire and emergency services. That is that's our vision. So I'm going to give pretty much a 50,000 foot overview of the agency. So USFA was created 1974, response to America burning. Fire still kills about 3,000 people every year. 3,000 people every year. It's 2023. So our goal, reduce the number of fires. Everything else gets better, at least theoretically. So reduce the number of fires, reduce the number of injuries, reduce dollar loss, reduce civilian fatalities, reduce firefighter fatalities. Ultimately, that is about as clear-cut and romanticized a goal as we could possibly have. And it's still a challenge. That's why there are a whole bunch of people that spend a lot of their time trying to affect that change. So where we reside, there are 4 major divisions under the Fire Administrator, Dr. Lori Moore Merrill, the Deputy Fire Administrator, Tanya Hoover, and the 4 divisions that support all of the work that's done. So first is going to be all of the facility management. That's MOS. That's one division. There is the National Fire Academy division, which everybody should be familiar. Hopefully everybody's familiar with. I'll talk a little bit more about that in a few moments. National Fire and Emergency Medical Services division. That is brand new. January this year, there was a reorganization that saw the creation of that division along with the EMS branch, which, as I mentioned earlier, I'm the interim branch chief for. Finally, the National Fire Data and Research Division. So my primary home is with NFIRS as the branch chief for the National Fire Data Center. That also incorporates research. There is an announcement about that if anybody is interested for a division director position for that division. So, all right, Federal Fire There we go. Federal Fire Prevention and Control Act 1974 defined America burning, defined the primary mission of the agency. It established the National Fire Academy, which is the education arm of the USFA. It's not operational in the sense we don't teach people how to be fire rescue EMS providers. We teach them how to perform the leadership and management in those and advanced training in those disciplines. In 2008, the FPC Act of 1974 was amended to include EMS, specifically coordination, the emergency medical services programs. The administrator shall provide a liaison at an appropriate organizational level to assure coordination of the activities of the administrator related to emergency medical services provided by fire-based systems with federal, state, local government agencies, departments, as well as non-governmental organizations. So that's the reason why we are here today. Our key initiatives. There are 4 stars. You can see, back up one. All right, I don't see it here. Different background. If anybody is familiar with the USFA logo, the hot foot logo has 4 stars. Those are actually extremely important, and they cover the key initiatives: data, research, prevention, education, and training. So the prevention section used to be considered community risk reduction. It is all lumped in together now, but prevention actually did a better job of messaging what it is we actually do. So public education and information, training and education, data collection and analysis, research and technology, and facility management and support is what supports all the rest. So all of those align with the divisions mentioned in the previous slide. So why a National Fire and EMS, division? So this is information that is straight out of the NFIRS system. This is 2022 data. This data is not released. There's still a couple of departments we're waiting to collect information from. We are looking at about 32 million fire department responses recorded in NFIRS, which is a pretty significant feat because NFIRS is number 1, a voluntary system. Number 2, not all fire departments report all incidents. So receiving 32 million incidents from the fire departments across the United States that's a pretty significant number. So if you look at the pie chart, the green shaded block, which is the largest block, the number is 67%. 67% on average of what the fire departments report are EMS based. So that number may seem low, and in the jurisdiction where I was volunteer, it was closer to 80%, and same with the jurisdiction where I was paid, it was closer to 80%. But 67% as an average across the country, that's a pretty significant number. Here's another good one. 23,404 fire departments. 90.1% is the number of fire departments that responded, percentage of fire departments that responded to an EMS incident. What does that tell you? If anyone knows, please feel free to blurt out an answer. 90.1%, what does that say? Exactly right. And if you look at the number of fires in the previous chart, that top little sliver is fire, hovers around 4%. It has been unchanged in years. 90.1% says 2 things. Fire departments do a lot of EMS, and the 9.9%, my math is correct, the 9.9% that have not reported EMS incidents just don't know they're involved in EMS. I can say that in this crowd. It's actually a really, really important thing because there's no fire rescue hazardous materials incident that doesn't involve some form of EMS. That is, and unfortunately, that's been an extremely difficult point to get across. Slowly, it is occurring. So the EMS is really a part of everything that is done in the fire service. But those 2 statistics alone, I thought were pretty powerful and worth sharing here today. So our EMS branch vision statement: informed, unified, equitable, well-trained, well-resourced emergency medical service system throughout the nation. Mission: to enhance and strengthen the nation's emergency medical services system's ability to respond and mitigate all hazards, emergencies, and disasters through program development, research, and support for organizational effectiveness, preparedness, training, and resilience. So envision this as sort of a 2-prong. There is our working with the agencies in the field, and then there is also us working with where we're housed, which is FEMA, which is a big component of the goal that we're trying to achieve here. Foster emergency medical services pre-hospital systems. Again, support equitable and effective emergency medical services pre-hospital systems throughout the nation. Transform emergency medical services pre-hospital systems' ability to prevent, prepare for, mitigate, respond to, and recover from all hazards, emergencies, and disasters. So it's not just the ambulance call down the street or the fire department response for manpower. It is also the emergency response surrounding a disaster. What agencies, what gaps need to be filled when there is a disaster. We have a pretty good idea of the number of fire trucks or hazmats or rescues in a particular affected area. It's pretty easy when there's a flood. You can overlay the flood in the geographic area and have an idea of the resources that may be needed to break even there are other factors that come into play. What's the response type? Are they career? Are they volunteer? Are they combination? Where do the people come from? Are they the same impacted community? So with the ability of looking at this from a holistic standpoint across all emergency services equities, that's the goal. That's the goal of being able to link this with disaster response so we have a better understanding in the disaster environment. This is all very new to us. So this is starting with a gap analysis, which I'll get to in a moment. Deanna Criswell is the FEMA administrator, and her words to us are in her 2023 annual planning guidance, goal 3, objective 3.1, strengthen the emergency management workforce, recognize and evolve FEMA training programs and resources for the emergency medical services. We must continue to lead the effort to advance emergency management by enhancing and strengthening the capabilities of all emergency managers and responders, including our EMS whole community partners. So through that was the direction to, in coordination with the Office of Response and Recovery and Resilience, to assess and evolve our current resources available to enhance and strengthen critical SLTT EMS capabilities to respond to, again, the all hazards through training program development and research. This is our starting point. So we don't have a lot to start with. It sounds very, very simple, but there is a lot to where we need to be. So the first thing that I have asked for, besides some of our projects, are going to be, what's the ecosystem? Where does the USFA stand in EMS? What are the interrelationships with the other entities? Who do we need to be involved with? Who do we not need to be involved with? Where are the gaps? What communication needs to occur? And here is a start to that. That wasn't me. So key initiatives, I mentioned EMS needs assessment, National Response Framework, Community Lifelines. Everybody, show of hands. National Response Framework, Community Lifelines. Familiar? If you're familiar, please raise a hand. 1, 2, 3. Are there 80 people in here? All right. So the lifelines are, the National Response Framework is how the federal government will respond to a disaster for FEMA. Okay. And the interrelationships through the course of how that disaster response is supposed to occur. Community Lifelines is essentially a red, yellow, green system of pulse check for various things for community recovery, safety and security, food, water, shelter, health and medical, wink, wink, EMS, energy, communication, transportation, hazmat, and water systems. And under communication is 911. So there are a lot of things that occur through the community lifeline process through FEMA, through a normal disaster response that does not have the integration of USFA and other EMS-centric stakeholders. EMS licensure compact, joint federal initiatives such as FICMs, and our sort of ever-growing research and technology, federal focus to enhance applied research and technology to safeguard medical first responders and ultimately the American people. USFA research, what we're doing right now, again, EMS needs assessment, responder safety study report. I'm not going to go through these. And if anybody wants a copy of this, please let me know. I'm sitting in the back row, happy to provide contact information, but just to sort of be cognizant of time. We're involved in a lot of things, which was one of the asks from the FEMA administrator of what is it that you're currently doing? This assists with providing an answer to that ask. All right, National Fire Academy. I'm going to go through this fairly quickly as well. Is anybody here, show of hands, familiar with the National Fire Academy? Yes. Wonderful. All right, there are EMS program. What's that? Odd House? All right, everybody's familiar with Odd House. All right, so the National Fire Academy is housed within the USFA. I showed that chart before. The divisions are equal at the National Emergency Training Center. Also on that campus in Emmitsburg, Maryland, is the Emergency Management Institute. If you have taken your ICS 100s, 200s, 300s, 400s, 700s, 800s, and certain numbers after IS, you have most likely taken an EMI course. So that's their virtual learning or e-learning arm of that agency. But they also do in-house programs as well at EMI. So Again, won't spend a lot of time on this as well, but there are a significant number of EMS classes. There are open enrollment periods. More information can also be found via the website as well. So here are just a couple of them: supervising emergency medical services, management of emergency medical services, quality management, mobile integrated health program management as well. The whole idea is to be able to deliver and enhance the education of the EMS providers in the country. Some additional EMS functions in ICS: incident operations, advanced life support for hazardous materials incident. Good class if anybody here hasn't taken it. I'm a hazmat person, so I don't glow. National Fire Academy's emergency medical services curriculum provides leadership and management education, leadership skills, futuristic vision, and networking. Networking is one of the biggest. I saw a lot of hands in here. Hopefully the networking opportunities there were as beneficial as the actual education itself. That's one of the biggest benefits I've found about taking classes there, being able to connect with the various students. Because if you've been to one response agency, you have been to exactly one response agency. It is done differently in neighboring states. It's done differently across the country. Rules are different. Culture is different, and things are just handled differently depending on where you are in the country. Some additional programs here as well. Again, I'm not going to go through in great and gory detail. Collaboration with EMS at the federal level. So these are going to be the agencies at the federal level. These are federal committees from FICOMs to NEMSAC, dealing with National Institutes of Standards and Technology, HHS, ASPR, CDC, NIOSH. Many of these were organizations, as I mentioned earlier, that we had involvement with when we were working with the COVID-19 response. There were, again, besides not being able to answer some very basic questions, if anybody in here has an emergency management background, the last place you want to be exchanging a business card is when you're face-to-face with someone on a disaster scene. And that's what we were doing. We were learning how to work with groups that had very different structures and missions than our own, and trying to collaborate everybody in the midst of COVID-19 was a little bit of a challenge. We'd like to really not have to go through that again. Lots of lessons learned. These are some national level organizations, everything from NESMSO through IAFC, IAFF, NREMT. These are organizations, they're not federal, they're, the NGO organizations that we're also either connected with directly or working with to collaborate with. So for U.S. Fire Administration in the EMS branch, that is all I have. Couple of points that I just want to raise really quickly. One, I am absolutely enamored with the discussions that I've had with people here and the concept that this is possible, because as Eric mentioned, I'm sort of his counterpart with NFIRS. And we have a very interesting relationship between our state NFIRS program managers, which is going to be very similar to the folks in this room, and the data vendors as well. The relationship here is cordial. It is collaborative, at least what I've seen. So again, first time here. If it's a facade, strong work. Very, very well done. But I think that it's absolutely fantastic. And I think it goes a long way to show that it is possible to actually have a good collaborative relationship across various boundaries to still have with a goal to still have a positive end result. And I think that's what I've seen here. So thank you all for your time, conversations with me. Last thing I want to raise is NERIS. The National Emergency Response Information System is the new version of NFIRS. NFIRS is being replaced. The timeline for that, we are looking at a standard development ongoing right now, a 2023, by end of calendar year, we hope to have at least a base standard developed. 2024 will be a gentle rollout to some participating departments. 2025 will see a larger rollout to more departments. This will eventually replace the NFIRS system as we know it today. Why? there are some data challenges we have. We have a huge data lag. We're just now working on finishing 2022 data imports. That's a problem because we still have a couple of months worth of pretty significant analyst review to go through. The timeliness of the data is a problem because we can't use it right now. So there are goals to try to change the way the data is brought to us by bypassing the state as an intermediary, so the end user would have that information travel to a national data set essentially at the time of dispatch. So it's the CAD is going to be the trigger point for incident creation. That's not going to mean that we're not capturing NEMSIS data in terms of having responders enter information, heavily reliant on APIs. And if there's no familiar with an API, just imagine an inbound, outbound mapping of data across two different data standards. So instead of having a firefighter enter, this is what this particular incident was, that can be pulled directly from NEMSIS to avoid, number one, the time it takes to create the incident, but also number two, to prevent any human interaction point that could potentially cause a data entry issue. So that's the very, very high level view, but I thought it was important to at least say a couple notes about that now. That is all I have. Thank you so much for your time. If there are any questions, I will gladly entertain. That was really quick.
Hi, David. Thank you. We have a question from Bill Clark in Colorado. Is there a way to determine how many of the good intent calls and false calls were dispatched as a request for medical response?
Ask that one more time.
Is there a way to determine how many of the good intent calls and false calls were dispatched as a request for medical response?
Okay. No. And the reason for that is NFIRS is based on incident type. So an incident type is going to be determined by what the unit found upon arrival. So if there was a medical assist incident that was requested, but that unit was canceled, then the incident type for that call would actually be a canceled, as opposed to showing that there was any sort of medical focus for the incident itself. Now, that being said, there are things that local jurisdictions can do through the use of a +1 code. I'm not sure if there is a NEMSIS equivalent to that. If there was a base code, say canceled, that is 3 characters long, you would add an extra character to the end of that. So maybe an E to indicate EMS. So all we would see is that the call was canceled, but for the local jurisdiction up to the state level, they would be able to see that it was canceled because of some other reason, like a number E to indicate that it was due to EMS. That makes sense?
That was an online question, so thank you for your response.
Sure.
2 questions. You said establish the nearest data set by the end of calendar year 23 and soft rollout in 24, right?
Correct.
So do you think that you guys will be adapting and changing the standard throughout 24 and have a final release near the end of 24 or early 25?
Is this the easy question or the harder question? So I think the way that the standard is being looked at right now is iterative. So the primary required must-have elements would be released first. From there would be the continual development of other things that may have been missed, or that agencies or the stakeholder groups have realized really should be included. Can't necessarily do everything all at once. So I don't have a really good answer for that specific question. But what I have been told is that over time, there are going to be edits and rollouts that are done to enhance the data standard as we go.
And could you just speak to how you anticipate linking up with either the NEMSIS repository, NEMSIS data set, so that providers don't have to duplicate their efforts when they go on EMS calls as fire providers?
Sure. So the way the NFIR system works today is that if somebody has an EMS incident, they have the option of filling out the EMS module. Those are going to be typically for your 300 series incident type NFIRS incident. Those are EMS incidents. It is not a required module. So one of the challenges is that, or one of the big complaints is for those that are not using a third-party vendor that pulls data from a PCR system, the individual has to not only enter the PCR data, they then have to go to their fire incident report and create the EMS module. Through the use of APIs, I don't believe that the way that the system looks today is going to be anything like the way it's going to look in the future. So if there is something that's EMS centric, that information is going to be moved directly from NEMSIS as it's available into the nearest system, again, via that API as real time as possible. That help?
So that was one of my questions. Thanks, Keena. And then you mentioned something about data collection for timeliness bypassing the state. I'm not involved with fire data collection anyway, but that always perks up my ears. And then my other question would be, do you have a list of who the state, you said you have state data managers are kind of equivalent of us for fire. Do you have a list by state who they are? Because I don't even know who it is for Arizona because we're not connected. I'm in the health department, as many are. And I don't even know where the fire is. I assume the fire marshal's not.
Correct. I'm going to answer in reverse. On our website, the USFA website, if you look for state NFIRS POCs, you will get a list of all of the contact information for all of the states. First part of your question. So right now, it is completely up to the end user, completely up to the state, how the states want their data submitted to them. What that means. There are certain states that have certain laws that require fire data to take a certain path. For some, it's completely irrelevant. It's just a matter of you shall report to insert entity name here. For some states, it means you shall report to the state, which will then submit the data to the USFA. What that causes is giant blind spots if we're trying to look at anything real time occurring throughout the course of the country, throughout the entire country. So if there are, I think there are probably 10 states, you're talking 20% of the country doesn't submit their data until perhaps the end of the year, after the end of the year. That means we don't have an ability to really understand what's going on, even with the phenomenal estimation methodologies that we use and that our analysts use for the data. We have those large blind spots. So bypassing that doesn't mean that states can't have the data. It's just pulled back for their use after the fact. Yeah. So okay, no, good clarification. This does not mean in any way, shape, or form that we're grabbing all the data, holding on to, and you're going to have to go through somebody like me to get it. It doesn't work that way. The data is going to be at the USFA. That's going to be available for use depending on your need and your user level. So states are going to have a different permission set than, say, a fire department in terms of dashboards and various types of analytics that they could perform. Good question.
Good morning. Really quick before the next comment. Our folks online need you to speak into the mics. And if you could remember to introduce yourself, it would be super, super helpful.
Dave, United States Fire Administration.
Trey Carpenter with Emergency Networking, kind of dovetailing on Keenan's question from Zoll. When are you guys going to publish documentation for third-party vendors to start building out the spec?
Great question. Don't know. So we don't even have a standard developed yet. So a lot of this is extremely conceptual. I should have brought the other presentation to give, but a lot of this is very conceptual. It's extremely aggressive, including the timeline. Some great conversations yesterday about how aggressive the timeline is. As soon as the information is made available, it will absolutely be released as quickly and as broadly as possible. The vendor groups are, so far as I know, informed, although I don't know if there has been a specific meeting with the vendors outside of some either sidebar, deliberative, or again, sidebar conversations at conferences with Dr. Moore. Welcome. So one more thing to that, keep an eye on the USFA NERIS website. If you go to USFA, actually, if you just web search NERIS, NERIS, you will get to a USFA landing page that is supposed to be updated regularly. That type of information and those types of announcements will likely be made there.
Hi, this is James Sasancio. With the data set that you guys are going to release, will you utilize a schematron?
Not sure.
So for us, a schematron is a mechanism of providing validity rules, right? Just ensuring that there's active logic checking as we're going through the data.
Yeah, so I think that that's a good clarification. So the way the NFIR system is built right now, there are a large number of rules and edits, probably similar to your schematron. Many of them are very fluffy, which if you're in an analyst world, you don't want fluffy, you want pretty clear cut. My belief is that anything that is done is going to be done in such a way that it is going to meet at the very minimum field parameter rules in terms of requirements for entering information in field A, requiring fields C, D, and E. That I don't know yet. I don't know how that's going to work.
Leetta Jackson from Botetourt County, Virginia, and the users like fluffy. But I'm a data analyst and I understand why you don't want fluffy. When you say real time, are you just making a distinction? What does that mean to you? Are you making a distinction from 6 months old? Or are you thinking minutes, seconds? I have several questions. That's the first one.
All right. So theoretically, anything other than the delay we have right now, where we don't even have 2022 data to analyze, is going to be more real time than what we have today. The belief is, again, conceptually, that as the incident is dispatched, there are going to be data elements that are going to be created immediately, times, locations, down to, through, geocoded level of specificity to start. So theoretically, real time actually meaning real time, as in not a minute from now, but now as it happens.
Okay. So that's a great segue to the next question of what percentage of the records you get would you say are entered in directly into the NFIR system?
Not sure I know what you mean by
you can go online and enter in your NFIRS data on the USFA website.
Correct.
So what percentage of the records would you say you all receive that way versus an import from a third-party system?
That's a good question. I'm not sure the number.
Okay. Because I would think how many people here who have in agencies that submit to NFIRS do it directly? And how many of you who submit use a third party? Yeah. And so just keep that in mind. The vendors' questions that we care to, that our vendors get the information from you all as soon as they can.
Absolutely. And that's been, and just so you know, I've been intimately involved with the vendors I've been doing this work as a contractor since 2003 for the USFA. So I have 20 plus years of experience working with the vendors. So they're not a forgotten group.
Okay, cool. And then you had said that you would be looking to NEMSIS for information. Would that be just to fill in on the EMS module or for perhaps the main module as well?
Yes. So I don't know that there's actually going to be an EMS module. That is for, for those who are familiar with the system, entering in PCR information and then having to enter the same for an EMS module in 2023 is ridiculous. It just simply doesn't make any sense. So I don't think that the EMS module, quote unquote, module as we know it today is going to exist in the new system.
Okay. And then just a comment, maybe we can do lunch or talk sometime later and you and I can talk about mutual aid. It's one of the thorns in my side. Not now.
You got it. Mine too, by the way. Mutual aid and what is not an incident if there's no response.
Hi, this is Josh Legler. Just a couple of quick questions. One is there a public process that people can follow and observe to see the deliberations that are going on, deciding the data elements, the structure, the API design, things like that?
Good question. Don't know. I don't know of one. The nearest website does have an update, basically a linear listing of updates, but I don't know if if those processes are public facing. The last that I heard was there were stakeholder groups that were either in development or have been developed and will be, meeting to have some of these discussions in the short term, but I don't know public facing during any quote unquote deliberations or whether it's just going to be after the fact where that information is provided.
Okay. Yeah, I would say that if you do open it up, you'll get lots of input like you saw today, for NEMSIS, where you've got a lot of different perspectives, giving their input and also being able to watch what's going on. So in NEMSIS, anyone can go to their JIRA site that has all the change requests that have been submitted for NEMSIS, and they can see what's in the works. So second question is, I was wondering what kind of interactions or collaboration you have going on with CAD vendors, since it sounds like CAD will be a key component of the data set.
So Dr. Laurie the U.S. Fire Administrator is working those angles now. The specifics of which I'm not sure. I'm not privy to those discussions at this point. But then astute observation. I mean, that is integral to the entire system. And there are 150 CAD vendors. Does that sound right? Trying to herd that number of cats to do the same thing in the same way, at least pointed in the same direction, the challenge. I just want to make one little sidebar note. I have business cards. If there is a question that I didn't answer adequately or said that I didn't know, for some reason I forget, you want to reach out. Pros, I won't take cons. You can give those to me here. Just kidding. If there's anything at all you want to comment on, please do not hesitate to reach out to me. I will respond to everything. If I don't know, I will ensure that it gets to the person that does know.
So being a former firefighter, fire officer, done many NFIRS reports, been dispatched to many calls that did not match what my report said. The dispatch, and by starting from CAD, do you envision having like a dispatch complaint versus what the actual type of call is? Because you guys don't have that now. And if that call is being started from CAD, most of my dispatchers were former cops. They don't care about fire. They don't know fire. They don't know EMS. And they're just going by the bystanders' information that was given on the other end of the call. And so the dispatch information is often way different from what the type of the call was.
So my feeling on that is I'm going to give a little bit of a philosophical answer first. So bear with me as I put on my my Socrates hat. The collection of more information does not necessarily mean it's going to provide any sort of benefit. So just simply adding data elements or fields or adding to a data dictionary can actually have an exact opposite effect, where you end up with so many choices. You end up with the paralysis of trying to enter information into a report. So it have an end result of being something that's anywhere close to being meaningful. That being said, that is, to me, an extremely beneficial component to add for the sake of education of one of the mantras that I have always used is, at least for the fire service side, is expect fire until you can prove otherwise. And I was sharing the story with somebody in here. I've been burned twice, figuratively, not actually, for incidents that were automatic fire alarms where there were fires in each of the incidents. So having an understanding of what people are being dispatched for and the delta between what they're dispatched for and what they find when they get there, that could be a very, very important metric, not only for educating the responders, but for educating the people who are taking the calls, because that can affect everything downstream. Because what the dispatchers are doing, what the CAD centers are doing, they're setting the stage for the interaction of the interface of the response community to whatever bad thing is happening. And it doesn't matter whether it's law enforcement, EMS, fire, rescue, et cetera. That's correct.
John Pringle with Water. We're a EPCR and inverse reporting data system. I'll take the mutual aid bunt here and throw it out there to you a little bit. Specifically related to boundary lines and jurisdictional overlaps, I think is one of our, I think one of the greatest challenges we've seen for agencies in actually losing data specific to responses that are in their jurisdiction when mutual aid is responding to within theirs. Now, I think we've been able to work with our agencies to resolve that. Do you have a plan to at least look at that and try and resolve some of those issues so the agencies can actually have real facts about the boundary drops and jurisdictional overlap losses and data that they have, so they can report on that in order to improve their statistics and demonstrate the needs that they have as agencies and organizations?
I sure hope so. The mutual aid challenge has been a really, really big challenge from the get-go because it comes down to definitions, and stop me if you've heard this before, but the way it's always been done. So you have entities that have responded the same way for generations, and data entry people today are taught by those that were doing it before. That's how I started. So I'm hoping that the concept of how how aid is viewed is going to be something that is analyzed with a lot of scrutiny. Thanks. All right, they keep on showing these numbers at the back of the room that I'm supposed to stop talking. So does anybody else have anything that they can think of now? All right, well, I want to thank you all again. Absolutely fantastic questions. To reiterate what I said before, please, please, please do not hesitate to grab me here, email me, call me, anything you can do to get a hold of me, please do so. I'm happy to discuss. And the question you just raised there about aid, if you want to email that to me, I will absolutely ensure that that gets to the dev team. Actually, it's NERIS, N-E-R-I-S at UL, because FSRI is actually the performer who's developing the contract for us. Outside of USFA is going to be the that's who I'll refer it on to. But if you want to send it my way, happy to ensure that it gets to where it needs to be. Thank you all. Appreciate your time.
Thanks, Dave. Just to say that Diane.
Thank you. I've been wanting to do that all day.
Just to say that the NHTSA Office of EMS will be working very closely with the USFA, as we have in the past, GAM and Dr. Moore Merrill, to make sure that every opportunity is taken to integrate NEMSIS without any duplication. And I heard the CAD question, Brian McGuire, who many of you know, Brian Tegmeyer, who many of you know in our office, who manages the 911 program for the Office of EMS. We'll be working with them as well. So we'll keep this group in the know with the information that we have through our data managers councils and through the other meetings that we have on an ongoing basis. So as questions come up, feel free to send them to Dave and bring them to our meetings as well. Clay, you want to introduce the next speaker? Or?
Yes, the next speaker is us again going through potential revisions for 3.5.1. There's a slight modification to the agenda you have. We're going to add an extra 30 minutes. We'll have an hour just to go through additional requests if we could. This is so important for us to get this initial feedback from this austere group. So again, just remember, I think what we're doing is going through these potential changes. We did not filter anything, right? So you can see there's been lots of different types of requests. Some are very valuable, some are barely valuable, right? We've allowed everyone to be reviewed. Those that we have had great consensus on in regards to either move forward with or to not move forward, that's what we want with this first go through. Any of these that have a split decision made, those will be reviewed in greater detail during our implementation calls where we can spend time on every single one of them. This way we can cull through those that we can move quickly through and move on.
No, I'll use this.
Okay.
It's okay. That way we have one more for runners to run around the room. Good morning. And for you online, Jen Correa again, standing up in front of the room, ready to entertain everyone. We're going to go ahead and get started because I really hope that we can get through everything. We have this morning's session. We're going to run until 11 o'clock, which is a little bit different than what you have on your schedule. And then we have one more half-hour session later this afternoon. And I know some people are departing, so we're going to go ahead and get started.
Jen, can you put up the QR code for a second?
Oh, yes, I can. Oh, yes, I can.
Reminding everyone, if you do have trouble getting the QR code, we do have copies of it on our phone. So just put up your hand and we'll come over and help you out.
And back into presentation mode. There you go. It should be showing up. Did everybody have enough time? Anybody need a few more seconds? I can always start counting. You know how much I like that. That is my time's up. Thank you, everyone. No. All right. And let me get back to the slide we were supposed to be at. Just 74. All right, so we are going to start where we finished yesterday, which is Survey 2, Question 5. We have found those slides that were missing earlier. So does anybody need to go back over these items that we were discussing? So we're talking about changes in the e-exam section. The first one we're talking about is e-exam 16, which I believe Clay is going to pull up so you can see what is available in that extremities location. And then everybody's going to have a chance to vote on the first two that we did yesterday as well. We're going to go ahead and start. So the first one is cool, cold to the touch as an extremity finding, not location. All right, so we're going to go ahead and move to the next one, which is addition to extremity findings, cyanosis. And addition to extremity findings for arrhythmia fleshing. And these are the three that we did yesterday. So beyond this will be new. Addition to extremity findings for hot, warm to the touch. All right. And the next one is lividity. Addition to extremity findings. Okay, the numbers have stopped moving, so I'm going to go ahead and move to the next one. Oh. I think someone waited for me to say that so that they could vote. Just saying. All right, moving on to the next one. Addition to extremity finding model. Yes, yes, that would be my typing again. You know, you only make mistakes when people get to see that work. All right, we're going to go ahead, give everybody just a couple more seconds. And I'm going to start at 3 today. 2, 1. All right. So addition to extremity findings, hail. All right, the numbers have stopped moving. So 3, 2, 1. And addition to extremity findings, obese. There was a lot of comments on this one, just in particularly to this finding. The comments were summarized that there were many who didn't feel like obese was a extremity finding. And it looks like that's pretty consistent in the voting today as well. All right, so we're gonna give you just a second more. 3, 2, 1. Just kidding. All right, additions to mental status assessment. This is e-exam 19. There was a request that was made to add a couple of items to the mental status assessment. These are available in the eVitals section under AVPU and GCS. Response to painful stimuli. Add it to the mental status assessment. Thank you. Hang on one second, Chris.
Eric Holmes. I live in Salt Lake City. I'm a Virgo, and I'm curious why we would add this when it's already an AVPU.
That is a good question. We'll go ahead and give everyone a couple of seconds here to change their minds. Someone get the man in the box. Just kidding. All right, so we'll give everybody just a couple more seconds on this one. And the next one is also for mental status assessment. Moving on to the next one. 3, 2, 1. Sorry, it's still moving. All right. Survey 2, question 5B2, additions to mental status response to verbal stimuli.
And this value is again in AVPU. So collected under vital signs.
And GCS, yes. Yeah, and that was Clayman, everyone. Who needs no introduction? All right, so I'm going to give everybody 3, 2, 1. All right, and so this is for additions to chess assessment findings, which is e-exam 24. Is it? Okay, all right. So we did. So this one was all under that first question that we looked at. These were all subbed for that.
I don't like this box. I'm Lauren. I like long walks on the beach and hugs. I'm just curious about this one because in 3.5 we broke it up so that it would have separate assessments. So what's the point of then reinstating this? Yes. What's the point in reinstating this when in 3.5 we broke it up so that they could have individual chest and lungs?
So the chest and lungs would still be separate. It's adding a chest assessment finding location of generalized. So it's a generalized chest location.
Yeah, we had that. Okay.
Good enough. Now we need to.
This is like the AHA CPR.
Yeah, this is a lot like that one. So it looks like most everyone has voted. And most of the comments were right about what was said in the room. It seems like we already have that. It's already available. There's not a need to add it. Okay. All right, so moving to the next one, which is also an addition to the chest assessment finding location, which doesn't actually, left side or left lateral. That's what you're voting on for this one. That you want to add that to the chest assessment finding location. And you can see the ones that we have available already up here on the screen, if you can see the screen. Does anybody want to raise their hand? And okay.
Hi, Samantha with ESO. Yesterday, we voted on one to remove the posterior anterior from chest location. If that goes, then all of these questions don't matter, correct? Because then we'll just have left, right, general, left side, right side? Because if we're getting rid of posterior, everything is anterior at that point.
If that one passes, yes.
Okay.
So everyone up, we've got Andrea. Frank?
So, I'm not sure what the question is. I think we already have left side, right?
Yes. They wanted left side, left lateral. That was the request. So it does look like it's already up there. So I think no would probably be a safe answer.
Okay.
Yeah, we could actually check that one off the box. I like that way of thinking.
Jen, is the question that it's keep it as left side, change it to left lateral, or?
So both suggestions were in there to add left side or left lateral. Now, does anyone think that the wording needs to be changed to left lateral? I guess that could be a part of it. But I think this might have come in before 350, and the person who reviewed the request, who's not standing at the front of the room right now, didn't realize it was already there. Didn't do a good job checking. So that would be the same thing for the next one here on C3, which was about right side, right lateral, which is on there already. So I think we can skip it and move to the next one. All right, survey 2, question 6, update the definition to E-History 01, barriers to patient care. Update the definition to indication of any patient-specific barriers to serving the patient on the scene or during transport. And you can see that the current definition really talks about the scene. It does not talk about during transport. The comments that were made, indication any patient-specific barriers to serving the patient at scene or during the transport. The words whether or not should be kept since none reported is an option rather than a pertinent negative. EMS provider agencies not necessary seems redundant, and other consider adding it as a separate element, but it may not be needed. So any comments, questions, concerns? We've got Chad from Kansas.
Chad from Kansas, Aquarius and kickball champion. My body's telling me that I was a champion today. It hurts. I would agree with a change in the definition just by simply removing at the scene at the end. I think this question means, did you have any barriers to care while you were taking care of the patient, period? Whether that was at the scene, during transport, or whenever. But did something prevent you or impact your ability to take care of the patient? So I would be fine with the change of just dropping the at the scene as opposed to adding a bunch more stuff.
Which would essentially do the same thing. So if that's the way, you could always vote needs more work, and then we can change that and update that. If you agree with Chad. All right, so we're going to vote. I should just say which one I want, before you guys vote, and see if that works on the next one. Two, 6. This is 3, 6. Yeah, that one is survey 3, question 6. Okay, that's right. We're going to get that one in there. We'll come back to it. There is, we just got to get it in the right place. So we will come back to that, but it looked like needs more work was pretty much, if we don't have a chance to come back to it because we ran out of time, you'll hear about it again. So survey 2, question 7, addition values to E-History 17, which is the alcohol drug use indicators. The request was to add values for bystander family report suspected alcohol or drug use and bystander family report witnessed alcohol or drug use. During the review of the comments, the state data manager said, making it too complicated, just have it be bystander family report alcohol or drug use. We only need one option. That pretty much summarized all of the comments. EMS provider agencies suggested wording bystander reported suspected alcohol or drug use and bystander report witnessed alcohol or drug use. May be legal concerns if patient doesn't admit it. Those were the comments that were made. Questions, comments, concerns, online or in the room? All right, we're going to hopefully vote. Yes. So you can vote between adding the 2 values, adding the 2 values that were suggested, adding the 2 values, or adding just one of the values. You should be able to vote no.
Jen, you have a question up here.
Is the choice for adding them both as one field I'd kind of recommend against, because you're going to lose that granularity, and alcohol and drugs are completely different in a clinical context. So to lose that granularity downstream, I think would be a disservice. This would be a useless choice at that point.
And I'm not sure why the no's not. So take a not voting at all as a no. And we'll probably revisit this one. Hang on one second, Barbara.
Barbara from San Diego. It looks like the definition will need to be changed also, if that gets added. The definition will need to be changed.
The definition would need to be adjusted to fit these new additions?
Correct.
Any other comments or?
I don't think the definition needs to be updated, because by the patient is the use of, not the reporting of. Kevin from Michigan.
Oh, thanks, Kevin. I couldn't see who was
Mark
talking.
from California.
So, and that would be something we could talk about in a different request. Okay, so let's go ahead and move to the next one. Survey 2, question 8. Add a new attribute to E-injury 09 height of fall, which is measured in feet. Currently, there's a comment for E-injury 09 that says enter 0 if it's a same level fall. The request was to add an attribute for the same level fall so that they would be able to mark that rather than putting in 0.
Okay, this one, oh, I'm Ann from Arizona and I'm a Leo. Eric, see what you started? Okay, so this is not mine, at least I don't think it is, but I have a story to tell of why I actually am in support of this, because it sounds like, oh no, this will be fine. I got an agency who called me and they're like, please solve this dispute. The new guy, the poor new paramedic was like, no, same level fall 0. And all the other guys are getting up and be like, no, you put their height in and that's the level of their fall. And I'm like, no. So I think having an option in there might just make it clearer. Because then we were trying to figure out, okay, if they have a height of 6 feet, did they fall from 6 feet? Are they 6 feet tall? We can't tell.
I think that's in the definition, the lowest point of the patient.
Leetta again from Virginia. We spend a lot of time training our guys that 0 means they had their feet on the ground. 0 inches between their feet and the ground or their butt in the chair. So we don't think it should be changed.
I worry about this change actually changing the technical use of this data element, because you're using a numeric piece for this.
Can you speak up just a little?
Yeah, so this is a numeric item, right? So if you were to add an observation that says same level, would that be like more like a pertinent negative even? Because that would change, you would have to like make a second observation here to be able to support that numeric and or the observation. Yeah.
Lauren, you need a mic. The people online cannot hear you if you don't use a mic. That was the kickball in action right there.
I'm almost to Chad's level. I was just saying a pickless value versus an integer would then create the development work for an additional element. Yeah.
Yes.
But then it would be a pick list of a single element versus a numeric one. So like keeping it at 0 and like taking on the training of telling people 0 is where your feet are on the floor would make more sense for maintaining this data element because of that. That's
right. And the end users, even though it's in the definition, they're not reading the definition on NEMSIS. So.
All right, let's go ahead and vote.
I'm gonna give this.
All right, looks like everybody has voted. 3, 2, 1, just because I thought you hadn't heard it in long enough. All right, so survey 2, question 9. These are new elements, optional or recommended, that would be added to e-medication section for why a medication was given, the indication for the medication. The comments that were made by the state data managers, free text would just turn into comments field, but an option list would need work. Medication should be given per protocol. Doesn't seem needed. Vendors, info is in the narrative description. Provider agency is redundant. Free text wouldn't be useful. And other need more refinement or discrete options. Are there any comments, questions, concerns from online or in the room? And please don't forget to introduce yourself for those who are online.
Chad from Kansas, still a paramedic, and would be pissed off if you asked me this question because my documentation throughout the rest of the ticket should tell you why I used a specific medication and the protocols that I have to be trained on in the agency. So to add additional questions like this as a provider is just infuriating because I should already be letting you know through my documentation and assessment why I'm giving a medication and following my protocols. So to ask me why I gave that medication just makes zero sense to me as a provider.
Turn the microphone off? Right. Jen, I concur.
So when I look at this, I think that, again, it's another piece of element. It's another element that can be informed by your protocols again, and informed by your impressions, right? So a lot of the reason that you administer medication is because of a condition. So you may not want to add a new element to have basically like a list of conditions that you would give this medication for, when you could probably put in a little bit of sophistication in the system that says, this is the condition, and this is the protocol, this is the medication. And yeah, free text of that might be terrible.
Any other questions or comments? Keenan, did you actually? Did Keenan want to say something? All right, let's vote. Add a new optional element for your medication section about why. Well, that was quick. All right, we're going to give everybody just a couple more seconds. 3, 2, 1. And we go to survey 2, question 10, add an attribute or new element for procedures and medications as a way to indicate when this was done by another member of the unit, by someone other than a member of this unit or crew. And that's for when you're doing things at the same time on scene rather than prior to arrival. So it would kind of be like that.
All right, this is Ann from Arizona. Thank you. So this might not be mine, but I do get this comment a lot from my agencies, partly because we were like, if you did this, you need to say you did prior to arrival if you don't have this information. And they're like, but I didn't do it prior. I did this, and then they were on the scene with me. It wasn't prior to my arrival. I was there, and I was like, well, okay, the idea of it is, but I think that was at least our use scenario, is they want to be able to document that they did it on scene with someone else. There's mutual aid. There's all kinds of things where you're still there. Well, I don't know. Yeah.
Sorry, I'm Rob from Unified Fire. Also, this is already documented. You just say who did it. So all of this maybe is a development issue. You just assign who did it. So if it's another agency, you say the other agency did it.
In e-procedures 10.
It's already possible in the software, so I think it's a development issue. We do it every single day in our agency today.
So, hey, Clay, could you bring up e-procedures 10 out of the data dictionary? That'll give you the list of available options for who did a procedure or medication.
Yeah. Well, it's in the same vein as that. And so, you have the performer of a procedure usually, and this is like in like HL7 and everything. Yeah, in HL7 and all the other healthcare entities, the performer is the one that you notify, and your system should be able to see that that performer is not listed on your crew already.
Yeah, that's it.
Oh, it'd be either like a bystander performer or a different crew performer. You'll put in a name, or like you can put in like names and pieces there.
He was saying about the name.
And so I had Clay, for those of you who are in the room, and if you're online, if you look at e-procedures 10 or e-medications 10, that's the element that they're talking about, where you can document who did the procedure or the medication, and it has a list of the types of people. James also. David from Beyond Lucid.
Just want to address that, I guess some softwares do allow you to enter the name of the person who did it, but that's not part of NEMSIS because NEMSIS only takes in e-procedures 09, the ID number. So if you have their ID number and enter that, then yes, you can directly enter it and not have them on your crew. But otherwise, it might be a software specific thing, but it's not. The proposal is to add it to NEMSIS.
Correct. So if you have their ID number, you can enter it in a different field, or you can say the role or type of person in that one. Hang on one second. James from Sancio.
Your box is dead. So this comes up quite often with a lot of the states, particularly when it is very common for the crews to document that someone else, maybe from another agency, performed a procedure or a medication. The problem that a lot of times we run into as a vendor is there are states that are requiring an ID number, a value for eProcedures.09. So has there been any thought about, instead of having to make up some number in order to pass the validation, maybe if they're putting in agency A, send that agency's provider number in eProcedure.09 to identify that it was a crew member from that agency, as opposed to having to put in a number for a particular crew member?
That's a great idea.
Jen?
Keenan from Zoll.
Yeah, I think a lot of it has to do with the disparity of how people are charting in different states, right? Some states say if you're an ALS fly car and you go with maybe an ALS transport agency, right? And so now you have two paramedics doing their thing for the same patient. In some states, they say, paramedic A, if you did whatever procedures, it goes in your PCR. Paramedic B, if you did X procedures, you put in your PCR. And in some states, say paramedic B, all of your procedures need to be in your PCR. Does that make sense?
Yes.
So probably the question of how do some states handle that situation? I would like to call on the great man from the state of New York.
All right, this is Peter from the East, as opposed to Peter from the West in Oregon. New York you can certainly write a narrative that says, we performed this particular procedure, or this was performed by provider A from another crew. That isn't well received in some areas of the state. However, when it comes down to comparing the two and looking at the legal documents that they are, you want them both to be accurate and right. But if they're being written by two different agencies, you open yourselves up to question on protocol and reviews as well. So we require each agency to write their own.
So Chad from Kansas, Keenan are in Kansas, how we approach that specific scenario is exactly like Peter said a little bit, is if it's two separate agencies, we expect a report from each agency on what the agency did. If it's one agency and it was a fly car that got there first or somebody else that got there, then we just expect it to be one report on the patient, and they should be able to add that crew member in. The thing that we've done to tackle the issue of maybe a first responder from a fire department that administered a medication before EMS got there, or even while EMS was there, like in a cardiac arrest. I've got a fire guy that's a paramedic that's doing some skills. We actually had, we basically tell agencies just to build a user in their system that and a lot of them are doing it based off of their fire department. So I have an agency that has 7 fire departments they respond with, and they just have a generic user for each fire department that is, Andover Fire Department. And whenever one of their people give a medication or do a procedure, they put the user ID ends up being a number associated for Andover Fire, and then they put what level that crew member is. And so that way it can be traced back to that. So basically we're using a user ID and tying it to each one of those fire agencies. And it's generic. So we do the same thing with students. If they have a student riding with them, we're not going to give them a state ID to use in eMedications 09, and there is an option in 10 to use students, but we have a generic, we go ahead and make a generic student code so that they can have that in both fields and answer 09 and 10. Yes, yeah.
There was another comment that said that would work if it was done the same way on a national level. All right, and this is we got 2 more comments and then we'll go to the vote.
Am I good? Okay.
Yeah, go ahead and then we'll go to Ridgely.
Okay. Mason from Nebraska. I enjoy short walks to food. So As a acting paramedic, and maybe like it was brought up, disparities between how states have people document, but I don't think it's appropriate for me legally to be documenting what somebody else did, because if I document it wrong, that can come back on me as a licensed paramedic in court. So to me, this doesn't make sense to be documenting what anybody else did. If it wasn't me and my crew, I don't think it's appropriate documentation.
Perfect. And let's go to Ridgely in Massachusetts.
Originally from Massachusetts. Could we just add something into that list that instead of saying, EMT or paramedic, it says EMT or paramedic from another agency or another unit? And it keeps it simple.
That would qualify under like the needs more work, that the idea has merit, should be still considered for inclusion, but needs a little work. So I'm going to go ahead and everybody can vote. I'm going to give about 5 more seconds on this one. I know there was a lot of discussion and thought, and I would just like to say while you're all voting, thank you. Keep talking about it, because that helps everybody decide how they're going to vote and maybe bring up something they haven't considered before. All right, we got 3, 2, 1. Moving on to the next one. Survey 2, question 11. This is a new element, and Josh, I do believe this is USCDI alignment, part of the interoperability. It is a new element for the patient insurance ID. This would be the ID assigned to the patient by the insurer, not the patient's policy number, which is what is collected in e-payment 18. And you can see that was a question that came up a lot in the comments. So this would be different than e-payment 18. Chris?
Yeah, and I'll just mention that I found.
And that's Josh.
Josh Legler, sorry. I found this in my review of the comparison between NEMSIS and USCDI. That said, I don't have billing experience, and I don't know, how critical this is. I just noticed that it was a discrepancy between the standards.
And we got Andrea. All right, Doug, you got your microphone first. Go ahead.
I think the element name is really confusing. I was one of the people who said, what's the difference between e-payment 18? Just because it's not clear. If it's something that comes out from outcome data, maybe it goes into outcomes, but the name probably needs to be clarified that this is not the policy number from the insurance ID, because right now it's redundant as worded.
Andrea?
So I think in terms of USCDI and why it's in there, I think this is more applicable for maybe a hospital system to include in terms of like if they have a patient that they have like queried the insurance company and have it on file, then they can use the patient ID for, connecting them to certain chart pieces. I think, as far as I know, on your insurance cards, you don't have your patient ID either. So this would be more of, I would say, if you were to implement this, it would be more of a back-end element for like repeat patients and things that you have the ability to store it from interacting with the insurance company, and not necessarily something that you would get at the patient at the patient side for data collection. Just to give some of the context of like why it's in USDI and why it's there, it's not a bad thing to have structured, but I would say it may not be like a priority right now.
So this would not be something you would expect the crews or the EMS clinicians in the field to populate. Okay. And we have one more from Adam Milford. Hold on, Adam. We're getting there.
Oh yeah, Adam from Zoll, I was corrected. But I know this is going to file under needs more work, right? But the other, I guess, way to do that is e-outcome 03 and add a new a value under external report ID number type. So you could add in like insurance or something like that if you really needed to track additional ID numbers.
That's another good idea. Oh, okay, one more comment, Josh.
Yeah, and under the US CDI structure, this is clearly in the payment category of US CDI. So this would be an addition to e-payment dot insurance group where we already have like the policy number. This would be the patient's ID number that the insurer assigned to the patient. So this is where it would go for sure. What I don't know is how important it is, whether it needs to be added in to NEMSIS 351. US CDI calls it the member identifier, if that helps.
So that could be a name change under Keenan from Zoll.
General question, have this and the other payment and service level questions been run by the billing user group yet?
They have not, but they were able to, so the surveys were sent to the billing stakeholders as well to review. And the next one is a lot like this. So we're going to go ahead and vote. It's just yes or no. Should be a needs more work there. All right, I'm not seeing a whole lot. Oh, there we go. Oh, well, that would be why there's only a yes or no there. Should this be, if you want to change your vote, it is remove this from consideration for version 351. I was awfully tired, apparently. Oh, look at those changes. See, thank you for reading. That just shows me someone was paying attention in there at some point. All right, giving everybody a chance to change. Just be prepared that the next one's worded backwards too, guys. Sorry about that. So for survey 2, question 12, this was also from the US CDI, and it probably also has a slightly different terminology in the US CDI. Can you check on that for me, Josh? This would be a new optional element for the insured insurance ID. It's kind of along the same line. It's the patient, the ID assigned to the patient by the insurer, not the patient's policy number.
Yeah, so this is the person who holds the policy, like it might be the patient's parent, for example. This would be an ID assigned to them, and US CDI calls it the subscriber identifier.
And again, this would, if it got approved, would probably end up in the e-payment section. And it would not necessarily be something that the EMS clinician in the field would populate. So are there any additional questions, comments, or can we go see how I worded this question? All right. Nope, this one was the right way. So look at that. A new element for insured ID. Should this request move forward for development? Yes, needs more work, or no. All right, we're going to give it just a couple more seconds. And 3, 2, 1. Moving on, survey 2, question 13, expand the max inclusive of SNOMED CT codes to 18 digits. We are going to let you vote on this, but it really does need to be done, especially as we move into, you know, more procedures being done out there. SNOMED CT codes are getting longer. We really do need these 18 digits. So this is more likely to happen than not. This is not something the EMS clinicians would see. They're still just going to see the name of the procedure in your different various vendor products. It's more of a back-end change. Any questions, concerns, or comments? Go ahead, David Saylor from Beyond Lucid.
Is there any additional pattern constraints that might be helpful rather than just making it arbitrary digits?
Josh is going to answer that as my technical advisor.
SNOMED says no. SNOMED says that it's a, how many bit integer? I forgot. That should be displayed using digits with no leading zeros. That's their only constraint. So the particular number of bits they use for that integer means that it's going to be up to 18 digits, and that's it.
How do we ensure that this?
Keenan from Zoll.
How do we ensure that this is going to be backwards compatible? I have concerns. If we're max inclusive gets longer.
This is Josh Legler. Forgot to introduce myself. So any record created in 350 would be restricted to the current length, which is 14 or 16 digits. So all of those values would continue to be valid if they were validated in a 351 schema. 351 will allow more codes to come through that would not be valid in 350. So again, we have backwards compatibility, not forwards compatibility.
All right, we're going to go ahead and vote on this one. Aw, thanks, guys. Well, on this, it looks like you have options, yes. All right, we're going to go ahead and move forward on that. Survey 2, question 15. Update element titles and definitions for everyone's favorite E situation 07, chief complaint, and atomic location, and update the title of E situation 08, chief complaint organ system. So what this is the feeling of the person who submitted it was that the anatomic location and organ system applies more to the impression than the chief complaint. And so updating those to reflect that would be a good idea. Any questions or comments? And if E situation 07, is that up? So is up there if you want to take a look and see what types of values are there and what people are marking. And if someone could get a mic to Ann from Arizona. Get the mic, Ann, so people online can hear.
Okay. So, oh, sorry, Ann from Arizona. So I know that I had this issue. I don't know if I was the only one that noticed that we don't even use this that much, but the agencies do sometimes. So the chief complaint, the text field that no state will probably ever use, but it's important to agencies, says it's what the patient said they basically believed was wrong with them. Cool. This is chief complaint anatomic location, which for me would be like where the patient says it hurts, but the definition says it's where the EMS personnel says. So I don't know how everyone's using it, but I don't think they're using it the same. So either it should be from the patient like the other chief complaint, or something needs to be changed that it's clearer. Unless y'all disagree, and then that's fine.
So we got Keith. Chris.
Keith Finch with GMR. So for this one, it's basically whatever the patient, if the patient says my foot hurts, it's still the provider's impression as a medical to say where that foot injury is, to choose the extremity. So wouldn't it stay to that? Because we're asking the medical providers who are at the scene doing it to say what part of the body is being told to them that's injured, not specifically what the patient said.
Okay, hang on.
How is this different at all from a assessment field?
Okay, say that again.
How is this at all different from the assessment field? I would say get rid of this because you're doing an assessment where you're identifying anatomic location and all that sort of thing.
Lieta?
I'll answer that. As he said before, we interpret the definition as chief complaint is what the patient said versus the provider's impression and the assessment that are what the provider saw and observed.
Clinical versus.
David, do you have a mic? Okay. All right. We'll take one more we'll go Jeff and then Andrea. We'll take two more comments.
Yeah, so when we were looking at this, right, if you scroll up on there, it says that these fields, along with, E situation 09 primary symptom, are grouped together for the EMS reason for encounter. And so that's where we had confusion because, right, it's the two were named chief complaint and there's another field that's chief complaint, yet they're saying this along with the primary symptom is grouped together. So to me, it seems like it's more related to the symptom versus the chief complaint. Like it seems like it goes with e-situation 09. And so the language seems like it should match that.
Yeah, that's a great question, and thank you for bringing that up. I think that reference to the EMS reason for encounter probably needs to be removed. That was actually developed by Dr. Greg Mears years ago, and it caught some steam for a while, but it's not utilized anymore. So we don't calculate an EMS reason for encounter based on grouped elements anymore. So that probably needs to be removed. That's a good comment.
So this might, Andrea, this might be one of those ones where everybody wants to look at needs more work, so we could review it a bit.
Yeah, and so in terms of like in the generally how this is being done in healthcare right now is that your impressions and symptoms are like observations, and they keep them agnostic between like a chief complaint or like a primary symptom impression. So that it's mostly you're documenting that condition with like the body site, right? So, you know, granular chief complaint data is not defined either, but it's definitely one of those things where you can say it's the location of this would be there, but maybe not something like the organ system, because they might be a little too specific. So I think it would benefit from being more agnostic and saying you can use it for either chief complaint or your impression or both. That way you can have that variability.
Okay, and Maura, go ahead. And then we'll vote.
Maura from DC, I'll be quick. Maybe it should just be, instead of as identified by EMS personnel, instead be as reported to EMS personnel. And then impressions and assessment would be identified by EMS personnel. That way they're separated.
And it sounds like everyone's pretty much in agreement it needs work, just maybe it needs a little more look than what is here. So we always hopefully have a needs more work option on the next slide. All right, and we do. So you can say yes, needs more work, or no. And again, I have influenced you, I apologize. All right, and we have about 10 minutes left to go, and I'm going to go right up to my 11 o'clock because we are trying to get through as many as possible. So 5, 4, 3, 2, 1. All right, survey 2, question 17. Create a way to determine if times within an EPCR are CAD generated or hand entered by the EMS clinicians. State data manager comments, why is this needed? What is the benefit? Does it matter where the time came from? Vendors, how would this be implemented? Not seeing the value. EMS provider agencies don't see the value. They all seem to be right. The ones who voted no were all right around the same reasoning and comments that were made. There are options that were given in this, with the option 1 being a new element in the D DEM file, the D agency DEM file indicating where the agency imports from CAD, whether they do or not, whether they have that capability, or attributes being added to the date time fields rather than anything else. And I have a lot of notes on this one. I apologize. About 65% from the survey were in favor of the change, and of those 24, the largest number liked option 3. And so let's go ahead and look and vote on those options again. Oh, sorry. Any questions, comments, or would you like to look at the options first and then question, comment, and discuss?
Chad from Kansas, I would just like to know what the theory is behind this suggestion of determining whether it's EPCR or CAD generated. The majority of agencies in Kansas honestly don't even have CAD. Our rural nature, but our flight services, they have their flight system, but that they can grab that from. But I just don't understand why it matters whether a time came from what a dispatcher entered or what the crew tracked on their own. I don't understand the reasoning for that.
Peter?
Peter from New York. When completing investigations into quality of care, care errors, or negative outcomes, whether the time is accurate or not can be questions if a CAD entry was manually adjusted by an EMS provider to more match what would benefit them down the road if they made a mistake, or if the CAD timings are not able to be edited, as there are in some systems in our state. When it comes down to an investigation and answering the questions from the law firms, I don't know if Ryan is still here, but if the law firms of Dewey, Cheatham, and Howe, this actually does come up in our investigations and the work that we do.
Jen.
Oh, no. Okay. Keenan from Zoll.
Aquarius. This looks like a simple request. It's actually a much harder implementation than you probably think it is. It's a much harder implementation than you think it is. Number one, if the time comes from CAD and we mark it as such, and we can output it as an attribute, but then we now need the system to figure out if the user changed it or not, and if they changed it, then it's no longer a CAD-generated time, and so the attribute would have to change, and it's an attribute change, which is a lot different than just a regular, here's a new thing. And those things are typically in the audit logs of our software, if you really need it.
So some softwares may have audit logs that generate this information? Okay.
And this is Jeff, so I just want to make a comment on option 3. So with some of our agencies, the at-patient side date time, sometimes they can come from CAD, and sometimes they might enter it in manually if they didn't get it from CAD. So doing it in the DEM file you couldn't always say it's always from CAD or always not.
That's a good point. And then we've got Chad from Kansas, and then we're going to get into the vote because we are running out of time.
Chad from Kansas, just back to Peter. So wouldn't that be, because we have that same issue come up in investigations in Kansas, but during our investigations process on anything that involves patient care stuff, we go directly to the dispatch center and get a copy of the times that they have in their CAD system, and then we compare it to the times that are in the patient care record. And that's part of our investigation process and our getting all of the information from everybody we can to really determine whether or not a crew member changed times for their benefit on that piece. So.
Thank you. All right, let's go ahead and vote. A is yes with option 1, which was the new element in D agency section of DEM file indicating whether they imported times from CAD. Yes with option 2, new element in D configuration section of the DEM file. Option 3, new attributes for all date time elements to indicate source of the date time information, needs more work, and no.
So, as folks may know, over this last year, maybe a little bit more than that, I'll go back just a little history. NEMSIS has always had a complete section that was associated with the development of custom elements. So we know that what's important in New York isn't important to Utah or may not be important to Utah. There can be differences among the different states. So having national elements that apply to everyone can be very hard, right? Or ensuring that that NEMSIS handles all this special attributes of state. So there's always been this custom element section. Custom elements are collected at the state level, but they never go to the national level. That's always been the idea. Well, with COVID, there was this idea, wow, early on in COVID, there was this request by the federal government to collect who had done travel. Who had made international travel in the last 6 weeks, right? That was, we need that right now, right? I mean, it was just this flurry of requests from the federal government to help us understand what was going on early on. So this idea of national custom elements became a reality, right? So we were asked to standardize how, you asked the question, have you done any international travel, or where have you traveled in the last 6 weeks? And then we gave that out to all vendors, and they tried to put it in their products very quickly. Well, so this idea of national custom elements kind of caught on with the idea that what if we developed national custom elements that allowed us to one, beta test some change we want to make to a national element. So for 3.6, what if we developed a national element, custom element? It's not in the standard, but it's available for states to use if they want to use it. And at the same time, it's kind of beta tested as to see whether or not it would be something that would be valuable to add to the actual standard. So we've done that, right? So a great example of that is the changes, the American College of Surgeons changes to the trauma triage criteria, right? So that happened kind of out of the blue a little bit for us. So we developed national elements and developed a document here to describe what has changed between the old American College of Surgeons trauma triage criteria, what are the new criteria. We developed national custom elements. Those were included in a critical patch later, but if states wanted to move right away, some states wanted to move to the new criteria right away, we put those in and they were able to use it. So that was, I think that was partially successful. So here's the National Custom Element Library. You can look through these. Some of these were associated with COVID. Recent travel, right? So eHistory 901 was a national custom element made immediately to help us with COVID. E-N03, there's one for the new trauma triage criteria. And then for those who participated in ET3, right, the CMS study to evaluate whether or not EMS could be compensated for treatment on scene or treatment to an alternate destination. Those type of elements were included in here as well. So I think we've come up with an interesting idea that came out of COVID using these, quote, national custom elements in a way that allows us to be immediately nimble, but not having to change the entire standard when something shows up for us. So I think I just want to ask some questions here over about 5 or 6 minutes, and I love some great comments from all the entire spectrum of the folks that are here. I think we've seen that we can use national custom elements to characterize or measure a novel or critical issue that comes up. And I think we've also, it can be a pathway for something that we want to change to make sure it's actually going to work, right? States could implement it, we can come back, and if it seems like it's working, then it could be considered for a national change. So I guess I just have a couple of questions. First off, do people feel like this has been valuable for this purpose? I see Adam shaking his head. Okay, head shakes, that's, any comments? Yeah, who has used it? So raise your hand if you're a state that used the national custom elements to help with COVID, when we did them like in weeks. Okay, so several states. How many states participated in ET3, so utilized these for ET3? Agencies within your states that were participating in ET3. Interesting. How many of them used them until the critical patch came out for the new American College of Surgeons criteria on trauma triage? Okay. So not as much use as I thought, so thank you, Keenan. Do people see the value here, though? Yes, comment?
Looking at state data sets, people are pulling in some of these national custom elements into their state data set. So it is being used, whether we have people in the room right now who are using them.
Okay, good. And another use, you reminded me of another use, we actually talked about it in the hallway yesterday, is that still, if you go to the custom element library, there's still many states that are trying to ask the same question, and they're still asking it in slightly different ways. Right, so this might be, a third use might be for the DMC to get together, the Data Managers Council and the SEMSO, and say, wow, all of you want to measure this thing, but we have variability across the country. Can we just come up with a national custom element? And if lots of states are using it, then that's a perfect venue, and maybe this needs to be a national element, right? Maybe this needs to be put in the NEMSIS standard. So I think there's some value there. I've got just a short timer. How about these questions? does anybody have concern over who can suggest a national custom element? I mean, I'd like to hear from the DMC, like how much control do you want to have over this kind of an idea? Or should we try to help facilitate the Data Managers Council to determine that, hey, there might be a need for a national custom element here? Any ideas about how we could maybe frame this up a little bit more? Or is it working the way that it's supposed to now? Yes.
Clay, we've been working on that, as you well know. We've been going, as the Data Managers Council, have been moving kind of slow on that. We're going to be discussing how to modify that next month at the council meeting. And by the way, you'll be in on that discussion. I haven't told you yet. I figured I'd wait till you got this out of your hair. And oh yeah, Eric, you too. I'm not going to leave you out. So yeah, this is my humble opinion on this and watching COVID and something else, and please feel free to support this. You know, we have one of the most incredible data systems, some of the most incredibly talented people throughout the United States, you know, and the council and the vendors and the capabilities we have. I just feel that if something comes up that's critical, we need to be able to adapt much, much faster than what we did with COVID. I think we could have really shined ourselves with the tracking on COVID. You showed the graphs, Clay, and how we did from once we got on board. But my vision and discussion for everybody else is we need to be able to act faster on this and be able to get through. And for council members, just so you know, I've kind of spilled the beans on one of the agenda items we'll be discussing next month on that. Happy to answer any questions on that.
Yeah, thank you, Jay. That's helpful. Any other comments on that topic? I'm glad that the DMC is going to take a stab at this. I think that's incredibly helpful to provide some additional structure. Oh, I'm actually going to use this. That's why I grabbed it real quick. Yeah, thank you. All right, so thank you for that. The other issue that I wanted to cover was this idea of the UUID. So NHTSA has recognized the value of this approach, and I'll just go through it quickly for those who need to be reminded or those who haven't heard about it. So in version 3.5 of NEMSIS, we're adding a unique ID number, a universal unique ID number called the UUID that trauma in this country has been incredibly excited about, because trauma is very interested in ensuring what's happening in the pre-hospital setting. And in fact, in the American College of Surgeons data collection, the National Trauma Data Standard, NTDS, 33 elements in that standard are pre-hospital elements. So they consider it critical to have the pre-hospital document. But often, the trauma registrar who sits in a hospital with a patient that suffered a motor vehicle crash, they've got their hospital record, but often they can't find the EMS record, right? For a variety of reasons. But there has been this wonderful idea, and the vendors have been behind it, that with version 3.5, if that UUID sits within the record, is there an electronic way to move that over into the trauma registry record, and then that UUID flows upstream to state data sets, it flows upstream to NEMSIS and to TQIP, which is the data set for the American College of Surgeons where the National Trauma Data Standard sits. And then that UUID is present to link these records together without names, social security numbers, addresses, any identifier of a hospital, patient, provider, nothing. It's completely, it's just a number. It's just a record number. So that's what the vision was. And I think it's happening, but it's not happening, I think, as quickly as we'd like. And there was some misunderstanding about how to use it. And so I think, even though we've tried to provide these documents, right, we've got technical documents that helps software vendors understand how to pass it and how to receive it. And we put together documents to help providers understand it, or registrars understand it, or to have states understand it. But I don't think we're really getting it to work yet. And NHTSA, of course, is incredibly interested in this for motor vehicle crashes, and they're who funds us, right? And that's who we hope will continue to fund us. And so they have a strong interest in this. I think there could be funding made available through NHTSA with this purpose, and Eric can speak to that. But if we can tie EMS records to FARS records to MUC records using this UUID, it would be incredibly valuable. So I guess I just wanted to ask, among states who've moved to 3.5 and among vendors who have done that, first, does any of the states have hospitals that are receiving a UUID into their trauma registry records? Fantastic. Jay, can you just talk for just a moment about who's doing it and how you made it happen?
I cannot take credit for it. Our vendor, the wonderful, let's see, I think he left. But we import from the EMS record directly into the trauma registry, and that UUID is carrying right over into that. So we're bypassing, they have to go external to get that. So I can't take credit that we're doing it outside. It was nicely done, developed in. I'll thank Doug and his crew for that type stuff.
Okay. All right.
Yes, we do. And they talk pretty well. There's a couple things that I want, and maybe they'll, since I announced I want it, they'll listen to my desires. Nobody else ever wants anything out of their vendors, do they?
So can states speak a little bit to perhaps what they see as a gap? Do states feel like there's not yet an understanding among your hospitals? Is there yet not an understanding among maybe the AG's office or someone that is concerned about the sharing of this data across data silos? I mean, are there any stated concerns, or is it just that is it not happening in other states that have moved to 3.5 because it's just not been well socialized? So if that's the case, what can we do to socialize this value, right? To really get EMS data in the hands of our trauma researchers? What additional products on top of these that can we develop that will help socialize?
Doug Butler, assistant to the Ann Voswing from Arizona. No. But the one challenge with the UUID, it works well if the patient registry is connected or at the state level to the patient registry at the state level. The challenge is you have a patient registry at a level 1 trauma hospital.
Okay.
And there's no requirement for that EMS agency that transported that record to send that level 1 trauma center's patient registry a NEMSIS XML. That is the challenge that we're seeing with this process, is there's no requirement, there's no forcing that process. And then so when they submit to the state level, the UUID is missing because they never got the NEMSIS XML at the local level. So the system works very well at the state level, but when you get down to the individual hospital who ambulance service gets there and they're looking for that UUID, that's their challenge.
I agree with what Doug's saying. And another issue that we've been seeing with the trauma registries is that it's not making it over, and the registrars are not doing like queries for those certain records. So we have seen that where customers have asked us how do they get that over? Also, some of us don't make the UUIDs available like within the charts. It's just an XML. So we've had a lot of questions from users and from trauma registrars.
Okay. Yeah. So it sounds like again, it's educational to a point. And I think what you're talking about, Doug, is maybe we need to decide how we want to reach out to states to make sure that it's right. But who can fix that? Who can fix that?
So it's the agencies, and they're pushing back on us because we're like, oh, you can grab it from the hospital, but you can grab it. And they're like, well, the ACS says it's not really required. So that's their stance is with this change from 3.4 to 3.5, when they removed the EMS elements from their data dictionary, the adoption hasn't been, I don't think there's emphasis on it from the ACS side. So I would recommend maybe more partnership with them to really express the value and the importance of this at all levels. I think the state level knowledge is great. I think it's once you get down to the individual hospitals to say, hey, this is really needed. This is important. This wasn't a part of the removal of the EMS or the optional parts of the EMS patient part with 3.4. I think that's where the focus needs to be, is really with that partnership and really emphasizing at the actual individual hospital level.
I'm just curious if you can give us some examples, maybe not publicly right here, but if you can provide Clay and I some examples, because you can say it's not required, but it is required if you want to take the data over, because they did away with everything to use this as the mechanism and they developed it. So this was not a NHTSA product. This was a product that was developed by NEMSIS with the states, with ACS for this purpose. So if it's not the desire now for ACS, which I'm thinking that's not the case, that this is more isolated than across the board, then we'll address that with them. But that's an interesting point. I've not heard that.
Yeah, I think the messaging, how they changed the EMS requirements with the 3.4 and 3.5 is confusing for the hospitals, because we have like, oh no, this is a requirement. This was they didn't require all these new elements until 3.5. Your state has switched to 3.5, and like we don't know what that means. And we're like, it's the new version of NEMSIS, and then we explain NEMSIS, and we give them the NEMSIS video. So we do all this process, but then they're like, is this really needed? Do we have to have it? If we do a site audit. So it's really kind of re-educating. So maybe if there was some kind of document that we can refer them to as a white paper between both parties. But I think the messaging with the ACS, with that change, really confused a lot of the local hospitals. And that's what we're seeing.
I have a comment online from Ms. Peggy Huddleston in Missouri, and she just wanted you all to know that the trauma hospitals are getting the UUID on the EPCRs in the registry.
Just to say hi to Peggy online. We miss you here.
Any other comments? Any other thoughts about how we could potentially, over this next year, work to improve the facile use of the UUID across your states or your hospitals?
Hey, Clay,
or among vendors?
Clay, this is Randall here with NEMSIS. We're also going to be meeting with the Trauma Managers Council to kind of help spread this word. There was a conversation between myself and Kelly Parati, who kind of runs that Trauma Managers Council. And we're going to be kind of advertising that, explaining what the 3.5 standard was and the change, and then letting them know state by state when they do switch over to 3.5.
Great, okay. All right, fantastic. It's been a great morning. We're going to break for lunch in just a minute.
So that takes us to Survey 2, question 18. This is add an e-disposition 30 value for transport by another EMS unit with a member of this crew to schematron rules in the national schematron. They want them applied to all of the rules that already contain transport by this EMS unit, this crew only, and transport by this EMS unit with a member of another crew. So that means that if a rule currently fires when they mark transport by this EMS unit, this crew only, it would also fire with transport by another EMS unit with a member of this crew. So that was the request. The list that you're seeing is the list of national schematron warnings that currently contain the values for transport by this EMS unit and transport by this EMS unit with a member of another crew. So are there any questions or comments online or in the room? Yep, and if anybody wants me to re-say that slightly differently, I'm happy to. We need to get a microphone for Clay. This is a change to the national schematron warnings, yeah.
Okay.
Sam from ESO?
So with this schematron rule change, we would be saying that there would be a warning level rule or warning level message triggered every time transport by another EMS unit with a member of this crew requesting all the destination information. The one that worries me is the cardiac rhythm on arrival. Like, to me, that one's really concerning. And all the transport information, it feels like we're kind of starting to merge two things that don't necessarily belong. So that's...
Are there other comments or questions or concerns? Josh, do you think there's anything important that also needs to be mentioned with the national schematron warning? And I do want to clarify, these are warnings. They're not errors.
Yeah, not really. The rule currently applies just to the unit that actually did the transport. And the recommendation here from someone is that it also apply to someone who's reporting that they went on board some other unit's transport. So obviously they remained with the patient through the transport, but on the other hand, that person may or may not have been involved in the decision of destination choice and things like that. So I think that's why the rules currently are the way they are. But yeah, up to everyone here. In particular, primary method of payment, I can see why that got a lower level of support, because my understanding is usually the transporting unit is the one that actually makes the bill.
I have a comment online.
Okay.
I'm trying to find his agency. Josh Nation. He does not feel that this is a great idea. He said it's a terrible suggestion.
All right. Andrea?
So I'm wondering if this is kind of a cross situation that, like, if you're being transported by another crew, even if you're going on to their rig, right? And this is just for understanding, is like, for your documentation, technically you've transferred care to a different crew and you're assisting now, right? So I'm not sure how, like, you would be capturing that they're being transported by another crew. I don't know how asserting that one of your members went on there to assist is relevant to the documentation of this run, because at that point you've transferred care and your documentation's ended, right?
Right. So the EPCR that marked transport by another EMS unit with a member of this crew, they would be responsible for all the same things that the unit completing their EPCR would be responsible for, that was transport by this unit with a member of another crew. So the same rules would apply to both EPCRs. And then Keenan from Zoll.
This is my annual soapbox of warnings at 3 o'clock in the morning for real providers who are sleep deprived and on their 20th call in 48 hours are useless, and they will remain to be useless.
Kevin?
So based on those last two comments, this happens all the time. We have a number of basic life support services that rendezvous with an advanced life support service. That patient's already on the BLS truck. The paramedic jumps on the BLS truck with his equipment. It's now his patient. It's not the BLS crew's patient anymore. They're responsible for all this stuff, except the billing one, because, like Josh said, it's the transporting unit that has to bill for that call.
So the BLS unit is responsible for all the same stuff the ALS unit?
The ALS unit, it's now their patient.
Right.
So I'm a crew member on somebody else's rig. And it happens, I mean, a lot, everywhere. It's not, but as far as I'm concerned, most of the people don't see the warnings anyway, in my experience, so.
Clay?
I just don't want to spend a lot of time on this because we'll have to do a new schematron file for 3.5.1 anyway, and we'll have to go through these rules. I'd rather get to changes to the standard, right? Just make sure that we're getting as many of those out of the way as possible.
Let's go ahead and vote.
Okay.
Yes, needs more work, and no. And everybody gets about 5 seconds to vote. All right, moving on to the next one. Survey 2, question 19. This is adding metadata elements to track an ePCR from creation through the National Data Repository. So every ePCR system that touched an ePCR would be noted within it, so you knew the path that the ePCR followed. State Data Manager comments the metadata should not require EMS clinician input but be auto-generated. Sounds like an audit trail issue. Is this needed? Vendors should be tracking this, not sure what values it provides. EMS providers, not needed. Most software collects this information for CQI. So any questions, comments, concerns online or in the room? All right, no hands. Let's go ahead and vote. And 5, 4, 3, 2, 1. Survey 2, question 20, review E-disposition 20, reason for choosing destination. So this would be adding additional values of closest, most appropriate. That term, I know it's kind of sort of there already. Beyond closest, most appropriate patient request, and beyond closest, most appropriate family request. State Data Manager comments, add description of beyond closest, most appropriate, and just have that one. Vendors, EMS clinicians not qualified to say most appropriate. Our clients state this is not an issue, and we could encourage billing professionals to make the decision versus the NEMSIS TAC. EMS providers, agencies. Not all EMS agencies operate in states where patients are allowed to request service to a facility outside the response area, and billing clarification is desperately needed. Just because a patient requests it, it could still be the closest, most appropriate facility. So the one thing to point out is that E-disposition 20 reason for choosing destination is a multi-value field. You can select more than one. So if your patient does ask to go there and it is the closest, most appropriate, both of those could be selected within that element. Any comments or questions, concerns online or in the room?
Leetta Jackson from Virginia. What's the difference between the existing closest facility choice and this proposed new choice of closest, most appropriate?
I can't answer that. I'm not sure what the different thought is. Brooke?
I think as far as that question goes, the closest facility isn't always the most appropriate facility. So the closest, most appropriate facility could be past the closest facility. So a specialty center would be an example.
Thank you. We've got Mara, Chris. We'll let Mara, and then we'll go ahead and vote.
I'm also not sure, but would it be to replace like using, because we usually see people use closest facility, protocol, and regional specialty center, just all three. Would it just be to replace basically that purpose?
All three have just been suggested to be added. Nothing's been suggested to be deprecated. So it would be those that apply. All right, so let's go ahead and vote. Yes, add all three. Yes, but only add a couple of the options. Yes, add beyond closest, most appropriate only. Needs more work, and no. All right, I'll give you 5. Give you your count on a 5. Let's be real, it's not really 5 seconds. 5, 4, 3, 2, 1. All right, survey 2, question 22. Increase the USNG values to allow for a higher pinpoint accuracy within 1 meter. It is important to point out that if we do increase the accuracy and you want to track it at 1 meter, you can. But if you want to stay at 10 meters, you can. So this just increases your ability to be more accurate. State data managers, not sure we need the accuracy within 1 meter versus 10 meter. EMS provider agencies, is this needed? Billing, this may be difficult for some EMS provider agencies. Any questions, concerns? Dave Saylor?
Just real quick, the GPS accuracy is up to 1 meter already, so this would bring them in line.
All right, I'm not seeing any other hands, so let's go ahead and vote. Yes or no? There's no way to needs more work this one. That was actually on purpose. Yay. All right, gonna start the countdown for those who are big fans of the countdown. 5, 4, 3, 2, 1. Moving on to the next one. All right, survey 2, question 24. Add new descriptions for eLabs 03 laboratory result type element to limit the need for the use of other description codes. If you did look at this in the JIRA ticket, the requester did give links where you could go and see the different types of labs, the results, and things like that. There's quite a bit of detail in the request. And there were lots of types that were asked, so we just kind of bulked this one instead of putting all of them into the survey. State data managers need a way to document iState as well. That would be just an additional addition. This would be used by IFT and not 911. EMS providers, if not done by agency, this should be information supported in the narrative. Other, I can see potential benefits. Billing, this may be pointing to some specific brand name tests. Any questions, comments, concerns in the room or online? All right, seeing no hands, let's go ahead and vote. Yes, needs more work. No. This also did deprecate a duplicate, which is indeed a duplicate value on there. In full disclosure. All right, not seeing too much movement. As soon as I started to say that, it moved. 5, 4, 3, 2, 1. Moving on to the next one. Survey 2, question 26. New recommended or optional element for sex at birth. State data manager comments, current gender is enough, can get very confusing, taking care of the patient but be respectful. Need a value in this for intersex. Provider agencies, will this replace ePatient 13? The answer would be no. This was in addition to, this is a new optional or recommended element. And then other seems redundant to ePatient 13, but there's also a note, this does align with other systems already collecting this information, such as USCDI. Any questions? Andrea?
Just for clarity, based off of what the comments are about redundancies, is that in medical healthcare, there is a distinction between like administrative sex and gender. And this is definitely one of those things where it may not be redundant in many cases, in some cases where it is different. And medical care can change based off of those results.
Thank you.
How does the baby?
Lieta?
Given the new options we have, how is it different?
There's a few other suggestions as well for changing the current ePatient 13 gender. This would be a new additional element. If some of those changes go through, maybe this might have to be revisited.
Yeah, we may need to talk about that. I think the overall recommendation is that there's 2 elements, right? One is sex of birth and one is gender identity, right? Or something like that.
Yes, and I think there's another one as well.
But we don't, there are times when we need to know the sex at birth, and there are times when we don't.
It would be optional or recommended.
Okay.
All right, any other comments, questions? We've got Peter from Oregon.
I also think that there's an element of this that's about developing patient rapport and developing clarity in data so that people feel like their gender identity is being collected and that that we're clearly understanding the situation.
All right, I don't see any other hands, so let's go ahead and vote. Yes, needs more work, or no? All right, I'm not seeing any more movement, so we're going to go ahead and move to the next one. Survey 2, question 27, new recommended or optional element for preferred pronouns. State data managers, they run along the same lines as some of the sex at birth comments. Not medically necessary, treat patient, be respectful. Can be a conversation, doesn't necessarily need documentation. Vendors write in may be appropriate. EMS providers, too many variants, doesn't affect patient care. And billing, EMS clinicians don't have time for this. Any questions or comments online or in the room? Nope. Got Peter from New York. What's in the box?
This is a strange little thing, or rather large thing. These values that would be assigned to this particular element, they change all the time.
Yeah.
Moving forward. And there are some software vendors who would be happy to hear what I'm about to say, and I'm sitting near one of them, I believe. The more we change these things, the more confusing and challenging it becomes to keep our providers happy and engaged and not cursing my name at 3 a.m. because we have 16 different methods of implementing the schematron that I provide them. This would also require a significant volume of education to come from the state every time a new pronoun comes out. There's a difference, and I agree with Peter from Oregon, which is good, in that it's a matter of establishing a rapport with your patient. Oh, that's how you'd like to be referred? That's how I'll do that. Versus, I'm not going to put this on this medical record because if I add one more mandatory field for a city that has 12.5 million humans living in it, they will come up and revolt around my office.
Any other questions or comments or concerns? All right, not seeing any in the room. We're going to go ahead and vote. Yes, needs more work, or no? All right, we'll go 5, 4, 3, 2, 1. All right, survey 2, question 29. Add new optional elements for the rejects pattern as part of the custom element configuration. This is more of a technical one, so I'm going to read my note. A rejects pattern is a format checking mechanism that represents the expected pattern within a custom element. Up there, you can see kind of what an example will look like. And so it's just basically saying this is what it should look, this is what it should look like in this field. It's just checking it for validity, kind of. And Josh, feel free to elaborate. I even actually have that in my note. Feel free to elaborate.
Yeah, so the request from someone was in the custom element configuration block where you say, here's the name and definition of the element and here's its data type. It might be an integer or a string or something. Also put in there, some pattern that the values that the custom element results should match to. I would say, and this is my opinion, the downside, or I guess the gap on this is that this is not actually used to validate the data. The validation of the data still has to happen in a schematron schema. So the custom configuration block is really to tell a receiving system that that has no previous knowledge of the custom element that's in the file. It gives it some information about how to interpret the custom element data, but we don't really need to instruct the receiving system on validating that data. That would be in schematron. So again, my opinion on that.
Any other questions, comments, or concerns? Oh, we've got Frank from CARES.
I just would agree, echo Josh. This doesn't belong here, and it's just a potential source of a mismatch in the data you would want to use for validity.
All right, let's go ahead and vote. All right, I'm going to do the countdown here. 5, 4, 3, 2, 1. We're going to move on to the next one. And we made it to survey 3. All right. And there were only 13 questions in survey 3, so if we do this right, who knows what we can get done today. First one, need to adjust how the E-situation O2 possible injury element works. Should it be changed to limit the recording of minor injuries is basically the question that it was asking. State data managers, you can see the comments up there, need more information, keep things simple. This element was not meant to define an injury as major or minor. There would be a large impact to current utilization of the element. This is a major change to the understanding of the element. Consider adding a new element. An injury is an injury. They had a lot of variance, as you can tell, more than most of the comments aligned. This one had a lot of all over. Vendors, this change would have a negative impact on EMS documentation, possibly causing mass confusion. There's a value in documenting when a patient has a minor injury. More ideas are needed to resolve the issue. EMS provider agencies leave possible injury as the lowest level determination between medical and trauma. An answer of yes indicates the provider needs to do a trauma assessment. Perhaps add another field that captures the severity, which then dictate if mechanism of injury and other trauma data is needed. For example, a second field with minor equaling minor issue to extremity, like a cat scratch. I wouldn't change this question. It sounds like the real issue is that vendors are driving too many validations off of this basic question, which is designed to capture all possible injuries, including minor. Are there any questions, comments, or concerns? Anne from Arizona has the mic.
Hello. Okay. Yep. Arizona. Okay. So first of all, I like the idea myself of adding an additional question as optional, because it is nice to go, is this a possible injury? Then you have your total population of injury. Do you think this is a trauma is also very important for looking for under triage. So possible injury, yes, no, gives you your total population of injuries. That's important when you're trying to do performance improvement and quality improvement and look at your training. Also looking at whether or not the person in the field recognizes if this is a possible injury and therefore taking them to most appropriate care, possible injury, or possible trauma, because one thing that we like to focus on is under triage to impact our training, because that's not getting the right level of care. And it's hard, if you use your entire injury population, it's a mess. It looks like people aren't doing, and it's not a trauma, it's a scratch on the face. So I like but I'm just kind of wondering, is that a small level change? Is that a 351 change, or is that a 36 change if it was optional?
Which change?
I'm just asking if we went with the provider's suggestion of adding an additional optional element instead of changing the existing one. Is that a 36 change, or is that a 351?
Adding an optional or recommended element would be a minor change.
Yay.
So if that's an option you'd like to see in related to this request, it would be a needs more work answer. And then we got Andrea.
So yeah, I also support an additional option. I think an additional data element, because I do agree with the description here, as in this is a yes/no answer set, and basically you're going to have to do much more training if you were to try to decontextualize this from saying, okay, this is only for like big injuries. Then you have all that nuance of what they think is a bigger, a major or minor injury. So I think this data element should stay the way it is and not really change the definition, but adding an additional like data element would help more than changing definition.
Okay. Are there any other questions? All right. Jay from Wyoming, I think it is.
I'm Jay from the country north of Utah. I'm just going to add in there just a historical thing for everybody. Those of us have been around for a few months, not including Brian next to me. We used to call this medical trauma. Then the trauma folk came out and says, well, trauma is a surgical disease. So then we had to change it to possible injury, yes, no. And I think the identification, we've already got this built in another component, minor or major injury, and that would be, we can use our acuity levels to say, hey, if the acuity is critical, then you could probably take that injury as being high. So I like it the way it is. It's very simplistic. It's either an injury or it's not an injury on that. It's just 2 cents worth.
Okay, and I'm not seeing. Okay, Andrea, and then we're going to go ahead and vote.
I would say I would disagree with that because acuity could mean anything. You can have injuries that are not traumatic and have a severe acuity. So like if you were having a stroke and you fell and you have an injury, you could not be a traumatic injury, but it would be inappropriate to use that as an identifier for these things. So I think having a more specific thing to identify it would be better. I just think that, sorry, I just had to disagree with that mechanism.
Nope, that's okay. So let's go ahead and vote. I'm going to give it about 5 more seconds. All right, moving on to Survey 3, Question 2. Add a new time element to track transfer between different units of same agency. There's a couple options offered for this one in the survey. New optional element for transfer of care to another unit of the same agency. Or option 2, update the information collected in E×08 to track patient transfer of care in the field. So the state data managers that said no said just they liked option 2, just change the definition of E×. Option 1 might be more work for developers, but would stop incorrect usage of E×08. Option 2, updating E×08 would be easier. No need to add additional elements. Vendors said it sounded kind of confusing. E×08 should be sufficient. EMS provider agencies doesn't seem to have an added value. Current E×08 works fine. Other updating E×08 seems more appropriate, and billing same agency would follow the patient. Are there any comments, questions, or concerns online or in the room? All right, seeing none, we're going to go ahead and vote. Yes, new optional element for tracking the transfer of care. Yes, adjust E×08. Needs more work, or no. All right, so we've got 10 minutes, so I'm giving you we're 1, 2, we're switching. So Survey 3, Question 3, add the ability for EMS clinicians to indicate when there is violence or struck by during an EMS event. We have talked a lot about that this year, so keep in mind all of the discussions that have been had. Add the ability to collect the information in NEMSIS. 94% said yes, but option 1 and option 2 were added. E other 06, type of work-related injury, death, or suspected exposure, additional values being added, or a new optional or recommended element to collect violence and EMS information. So state data managers said no, the current NEMSIS data set is not the place for this. Easiest, quickest is option 1, but adding an element may be the cleanest. E other 06 should read EMS work-related injury. Vendors or customers haven't asked for this. EMS provider agencies and EMS injury tracking system similar to INFR's firefighters injury reporting system is needed, but this may be a good start. A new element may be easier. And other was this is important to collect and should be a discrete field. Do we need to have any questions, comments? I know we've talked a lot about this.
Over here to chat.
Okay.
Chad from Kansas. I did want to make a comment because we actually require this in our 3.5 stuff because we realize as a state we suck at knowing how much illness, injuries, or exposures actually occurs to our providers in the state. And I think the issue is with this particular element is there just needs to be more work done on the values that are available in the element. There's some values in there that are good, but it doesn't cover a lot of things. And so I think, I would advocate for answering this question with needs more work so there can be more discussion about what values are available that would give us a broader range to really figure out what's going on. Because today what we have to do is they select other a lot, and then we have to give them a free text to type in other. And obviously, if people type that in, you end up with the same thing, but it's in there 10 different times because the way they typed it in or spelled it. So I would advocate for needs more work.
All right.
Hello, is this on? Isn't this the sort of thing that should be captured by a police record or first report of injury or something like that? Why would this go into the patient's care record, like the EHR?
Chad, again, I would just respond to that by this would be like EMS worker gets a needle stick. That's not a police report or going in any police record. They're just documenting that, hey, on this particular call, this crew member got a needle stick, and that's what's being tracked.
Well, doesn't this say violence or struck by during an EMS level?
It does, but I think what we've seen and experienced is I think my advocation is that violence and struck by should be added in as a value so that we can track everything that happens on an EMS event. And I do know that we have situations where we have had EMS providers that have been assaulted or have been struck that they never did file police reports. Sometimes they didn't even tell their own agency, and we're finding out that some of them, if the value is there, they'll add it in, but I don't think it's always reported to law enforcement. And so for me, I think those options plus some additional ones should be added in as values to see if we can capture it and get a better picture. But I agree that if you got hit by somebody, you should file a police report, but I know we found that we have a lot of people that are like, no, it's just part of the job, and they don't end up doing it.
So we've got Doug and Jay, and then we'll vote.
This adds a lot of value. It's data that's not being captured, and it makes sense to be in the vendor, the documentation solution they're using day to day. I'm not sure that this is the right element. I think that we should consider to have a group to figure out where's the best spot for this, but it makes sense being in the EPCR system. That's the system they're documenting. That's where they're putting the medical record. That's where they're documenting the care they provided. If they got assaulted on that call, that makes sense. So I would like this to move forward.
And then Jay?
I'm just going to ask, we've tracked this for a fair number of years, and we've done the enhancements on our system to do that. I'd sure like to see those enhancements added in here. And I applaud for Kansas for asking that. I've seen this over and over throughout time where legislation comes in to make it illegal to hit a healthcare provider, and the legislatures keep coming back saying, oh, no, we don't need this legislation, blah, blah, blah. And most EMS providers don't really report it. The other thing I wanted to say is there's a fair number of things in our report. I'm going to just call it, they're public health monitors. So this never gets printed out as part of the patient care report. This is just a public health monitor that we used. And I think it would be very good if we could get this injury information so we could get lawmakers to understand this is important. And Jay's 2 cents worth is if we could start getting more legal action against some of these people that are doing violence against us, that maybe we can get more intervention by the courts. I also want to say this does not apply to a dementia patient. This does not apply to an elderly that is not thinking correctly. But however, in my humble opinion, this does apply to somebody that's overly drunk, taking drugs, and causes that. And I totally disagree with the attorneys that look me in the eye and says, well, they weren't in their right mind. Oh, well, they made the choice to drink or take those drugs, and we need to get legal action against them so we can get interventions done. Sorry, I get off my soapbox on that one.
That's okay. Thank you. And this is going to be the last one we vote on. David Taylor?
Yep, just a quick comment, potentially, that they can have that violent interaction outside of a patient care context. So if they are getting coffee and someone steals their ambulance and they get hit by the ambulance at that time, it may not, the PCR may not support doing that documentation. It may not be outside that scope unless we adjust some of the scoping of the PCR or something like that. But that might, if we try to do research on it, it might be bifurcated where inside versus outside are you have to go to two different places to see it.
Thank you. One more. You want to vote on one more? Okay. So survey 3, question 4, add new elements to show which software created the DEM file. So these would be new demographic elements to show the ePCR collect and send software that created the DEM file. That would include the software creator, the software name, and the software version that the DEM file was made in. State data managers, agencies should know who helped them create the DEM file. Could be useful to states and NEMSIS for troubleshooting and doesn't require EMS clinician data entry. Vendors, this doesn't mean anything to agencies or states. If the DEM file is made well, this shouldn't be important. And these should be required elements. Questions, concerns, or comments on this one? All right, seeing none, let's go ahead and vote. See, you guys got some extra time. All right. And we're going to sneak in one more here. Survey 3, question 5, add a new date time element for pre-scheduled calls. We kind of talked about this a little bit before, and this is the same type of thing, but it's only being asked for as a new optional element called pre-scheduled date time. State data managers that said no, this could cause complications with calculating response times. Seems like a local issue. A better field might be promised time. And the ones who said yes said keeping this optional would allow for agencies to document it if desired, could help clarify data, and would be good for all calls that are scheduled ahead of time. Vendors not sure there is added value here or how it would impact response times. EMS provider agencies, this should be tracked elsewhere. Any comments, questions, or concerns in the room? And get there.
This, I didn't put this in, but I wish I
Originally
had.
from Massachusetts?
Originally from Massachusetts, sorry. ImageTrain creates something called an incident date, and it uses E times 01 if it's filled in. And for scheduled calls, it gets filled in with this information, not the day that it happened. And you'll have a date that's out there for, whatever it was created on January 1st of 2001 for every dialysis transport for the next 3 years. So this would clarify that, and so you could keep your E times 01 pure, and it's not being used for two different things.
Okay, Peter from New York.
in a state system that regionally, in several regions across the state, has significant issues with average patient offload times. And much of that is either a staffing issue or a system backup, because they haven't been able to discharge patients from upstairs to send admissions up to upstairs. And that's really where some of the backup actually starts. This could come in handy to help us identify where particular issues are feeding into that, and we can dig deeper into resolving those particular issues at a local level.
All right, any other comments, questions? We're going to vote, and we are at the end of our time. So it's a yes, needs more work, or no. And we've got 5, 4, 3, 2, 1. Thank you, everybody. Thanks for playing.
All right, thank you very much, Jen. Thank you for your attention. I know this is really mentally taxing to go through all this, so I appreciate your attention to the detail. If it's real quick, yep.
Karen.
Karen with South Dakota. One of the things that we noted in South Dakota with our transition to version 3.5 was there is an element that changed its definition and now has a national schematron rule, and many people were not aware of it. And that element is E times, and it's left scene, unit left scene. In version 3.4, it was you left the scene with the patient. The new definition is just you left the scene. So it's now required if you arrived on scene. And I don't know what the answer is to that, but it was never included in the summary of changes from version 3.4.0 to version 3.50, pardon me. So I just want to make sure people are aware of it. Again, we've had agencies and software companies become more aware of that as they've submitted data to South Dakota. And how many people did not know that?
Yeah, so we can revisit that. So thanks for mentioning that. We clearly need more time for that. I do want to take a quick moment to introduce Lisa Young, if we could. We have, while she's setting up, so we have kind of a free 30 minutes. I was going to do a presentation on agency reports, but we could focus on what Karin said. We could try to finish all of the recommendations for version 3.5.1. We can talk about that later. That'll be after Lisa's presentation and a break. But I do want to introduce my good friend Lisa. Lisa, as folks will remember, she actually was the director of NEMSIS when she first came to Utah and was first part of the University of Utah family and did a lot of great work there. Actually, she was instrumental in moving NEMSIS from an on-prem environment to an AWS.
You're giving my talk for me, so can you
sorry. So
he does this
Lisa,
to me all the time, and then I have nothing to talk about.
The time is yours.
Okay. I'm Lisa Young. I actually came to Utah from North Carolina about 5 years ago. Clay and Karin hired me to be the IT project manager. I progressed to be the program director, and now I'm the IT director. So it's really great to be here with you. Thanks for letting me spend some time with you. My team is here. I'd like them to stand up awkwardly for just a minute. So from your right to left, Terry Lacey, he's our senior software design engineer. He develops the web services and the validation for all the data that come through. We have Christine Mahler, who is the lead for business intelligence. So she's developing and leading all of the dashboards in Tableau. We have Michael Wunderlich, who's a senior sysadmin. He's keeping us safe and sound. We have Diane Hartford, who was the lead IT PM for the AWS migration, as well as she heads up the IT PMO for the university. And we have Alex Looper, who works in BI. He's a developer on Tableau dashboards. And then Tim Myers, who is our senior data architect, and he is essentially the DBA, or the database administrator, for all of NEMSIS data at the TAC. So thanks. Thank you for the warm welcome. So we have about 25 other IT staff that are back in the office and keeping the lights on and our systems running, so they couldn't be here today. So these are the chosen ones. Overall, we have a robust team of IT professionals that work around the clock to make sure that our systems are up and running and that we're receiving NEMSIS data around the clock and that we're able to serve up that data through the different tools that are available. I'm going to give a high-level overview of the NEMSIS migration from an on-premises data center at the University of Utah to AWS Cloud Services. But really, more importantly, my team and I are eager, and the NEMSIS TAC on the service side are eager to hear from you and your experiences through the migration and post-migration. Okay, so here's a very artistic photo of our on-premises data center from the side. Those are physical servers on a rack, and the NEMSIS program used to be hosted in 2 or 3 of those servers. So when you were sending data, accessing dashboards, the website, and all the tools on the site, you were connecting to a server at this data center. And in the rest of the servers, the University of Utah's Data Coordinating Center, this is the organization that supports the NEMSIS TAC, hosts data from other technical assistance centers and registries and clinical trials. So there's pros and cons to a shared data center. Considering our focus today is on the transition to AWS, I'm only going to highlight the cons. So some of the more obvious cons are finite resources. So in a physical data center, well, they're all physical, but on an on-premises data center, there's fixed server capacity, there's fixed amount of RAM, memory, fixed amount of compute, computational power, and in the cloud, which we'll talk about in a little bit, we're not constrained by those. As long as we have the money, we're not constrained by those limitations. Also, in a shared infrastructure, despite logical separations and robust permissioning, you don't benefit from dedicated end-to-end infrastructure. So what I mean by logical separations is, in a physical data center like this on premises, we have a server, and then we slice up that server into 20 or 30 virtual servers, and we keep them segmented by robust permissions. And that's how a shared data center operates, and their shared resources. Okay, so why this shift? So the primary motivation, as NHTSA told us to, they said we needed to move to the cloud, and I got Eric's permission to say that. So we needed to maintain an authority to operate, also an ATO, which is an official approval given by a government entity, and in this case, that's NHTSA. And that allows us to operate the NEMSIS system in production. We also go through NHTSA checks to verify that we're meeting security standards. So you kind of can think of this as the official thumbs up that we can be in business. We also needed to maintain compliance requirements with the Federal Information Security Management Act, FISMA. We always call it FISMA, which mandates federal agencies to uphold very high security standards on their information systems based on that data's sensitivity and significance. So in the case of NEMSIS, NHTSA has deemed us to be a FISMA moderate system. There are lots of benefits for AWS in the context of NEMSIS. End-to-end architecture tailored specifically for the NEMSIS program. There's flexibility and scalability. So I talked a little bit about, basically with unlimited money, which we all know we have, we can purchase anything we want. We can purchase servers, memory, compute, storage. We can just deploy that. It's called infrastructure as code, and it's kind of scary. And I think by the virtue of the NEMSIS system being in a dedicated environment, there are enhanced security controls, continuous monitoring and protections that are evident and that we can demonstrate. Personally, I think it was the right timing. I think the switch to AWS was timely for the NEMSIS program because of the program's growth, both in depth and breadth, the surge in the volume of incoming data, which keeps us up at night, the increasingly complex dashboard requirements, and the growing interest in our data sets by various agencies and researchers. And we need to make this data readily available without being constrained to geographic location, making sure it's high speed and people can download this easily. Okay, I'm going to shift a little bit to the migration strategy. So what you're looking at now is a is a project Gantt that gives the highest level, the highest overview of the timeline of our migration from the shared data center into AWS. And so this journey started in October of 2020, and then we flipped on the lights on, I think it was the end of May. Yeah, end of May 2023. So here in NEMSIS, both in the TAC and in NEMSIS IT, we love project management. We love plans and Gantts and timelines, and we like to challenge timelines. We love to collect business requirements. I think we're pretty good at it. And we like to deliver, hopefully on time, but certainly with a high level of quality. So in the case of the move to AWS, project management was key. And we adopted 4 key phases in our strategy: assessment, preparation, migration, and validation. So assessment was critical to our success. This is where we undertook a comprehensive analysis of all the services, and we scrutinized over 115 unique business processes. With the foundation of that assessment, we moved into the preparation phase, where we geared up for the move. There were over 1,800 tickets that represented all the changes that needed to happen flawlessly for the system to be ready to move. And then the migration, the actual move. And this is a monumental task where we transition from a shared data center to AWS cloud. So we essentially had to build in AWS the exact system using different tools, and sometimes same tools, as we had on premises, and make sure that was working flawlessly before we could turn off the button in Utah and turn it on in AWS. And then finally, validation. And this is the phase that ensured all the services, processes, functionalities, and there were thousands of them, were running optimally in the new environment. So while this was happening, Clay said, Lisa, we want you to just focus on AWS so you can stop supporting NEMSIS, right? No more new dashboards, no more new anything. We're just going to focus. And so that was really great. So in addition to keeping the lights on, making sure that we were being responsive to requests, working on bug fixes, I mean, our technical vendors here will understand keeping things in production, running 24/7, we were doing this. And I would say the validation was quite exciting, exhilarating, and scary, because what we were doing is, for a while there, for about 5 or 6 weeks, the data, incoming data that you send, would come into our on-premises data center, but we would also send a copy up into AWS, and then in real time, we were evaluating in detail the data to make sure that it was matching and that there was no issue with the integrity of that data. And we did that. These people in this room sat there and watched that data for 5 weeks until we were 100% convinced that the data that you sent to us would remain unchanged when it got to the cloud. Okay, so having described all this great work and success of the migration, I also want to acknowledge that this migration has posed challenges. And our aim with every project, small or large, is to continually refine our process. Your feedback directly influences future decisions and improvements. So the intent of this talk was to provide you a high-level overview of why we went to AWS and how we did it. But really, it's so that we could listen to your feedback, any pain points, any things that you might have seen improve in AWS. I'd love to hear from you. So with that, I'd like to open the floor for any questions, comments, feedback, observations, any of it. I think everybody loved Okta and multi-factor authentication, I heard. I see that in tickets that you all just love that. Is there anything about that process that made it harder for you to access our data via dashboards or submit data? Clay promised me that I was going to hear some robust feedback. I'd love to hear it.
Well, I thought...
Because I think, Clay, what they're saying is it went perfectly.
Okay. Well, that's fantastic. Are states accessing the NEMSIS dashboard and tools under the dual authentication at the same rate, frequency that they were before that was present? More? Okay, and why are you doing more?
I'm finding it easier to find. Sorry, Rob from Montana. I'm finding it easier to find the data that's useful, and that's why I'm spending more time in it, because before, a lot of times I'd just get frustrated. I'd find some data and just kind of stop. But now I'm spending more time because I'm finding more and more useful data.
Good, good, good.
That's fantastic.
Mason from Nebraska. As I know I'm not the only newer person here, I will say for myself more, because I'm new and was only around for a short amount of time before this happened. One question that I do have is, what is the inactivity timeout timeline once you're logged in?
I didn't expect that question. I think it's 15 minutes.
Okay, so, and my only reason for asking that is some people, myself included, will log in like to multiple things at the beginning of the day and might want to come back and reference something or run something throughout the day. And if it's a 15-minute time frame or something short like that, I understand you have to weigh the risks of security and stuff, but it also makes things a little more challenging when we're logging in and then being logged out fairly rapidly and having to re-authenticate multiple times a day.
Sure, that's a really good point. I experience that frustration also when I'm using, I usually have, 20 or 30 systems up. I'd say there's very little, when you're in a FSMA environment, there's very little autonomy that we have as a system to define some of those rules. And they're actually prescriptive. And if you ever get bored, you can go, it's riveting. So you can go to NIST 853. There's about 160 controls, and we have to be compliant with 100% of those. And then we get audited every year. Robust audit, takes weeks, and then we do it every year. One of those requirements talks about it's either 15 minutes or 30 minutes, but it says you will pop people out after this time period. But I do understand the frustration with that. And then you have to log in, you have to re-log in. Yeah, it's all in the name of security. And I will say that the system that we've built in AWS, while it was safe and secure at the University of Utah's data center, it is locked down, and your data are safe. And the audit logs, all the continuous monitoring. We have a cybersecurity partner that we've hired with Eric's approval to actually continuously monitor, spit out reports, make sure that we understand our security posture at any time. So on the flip side, I sleep better at night. Yes.
It's not Okta related, but do you guys, or have you considered like open sourcing some of the software so you could get like feedback? So like the cert validation software, that's something that I think we would have messed with, like especially like time zones and stuff. It was just a little confusing there. And so I was just wondering if that's something you guys would look into maybe.
That's a good point. I'd love to talk to you about that more.
Yeah.
What was your name?
Jeff.
Jeff, okay, good. Okay, can we talk after?
Sure.
Okay, great, thank you.
Okay, we have a question online, or actually it's not a question, it's a comment from Judy Whitfield in Texas. Texas had some issues with getting Okta approved for use on state agency cell phones. It has now been approved and there are no issues. I would like to know if other states are experiencing issues with getting the Okta approved for their state-issued cell phones, and if you need any additional resources from the TAC.
I think that's a fantastic comment, and I do want to address it. So there's a lot of lessons learned, and one of the lessons that I learned, which will apply to future projects, is we could have done a better job by informing you in advance of the changes to multi-factor authentication. So I think multi-factor authentication is here. In fact, it's been here for a long time. And what you'll find at the state and federal level is that that's just going to become a requirement pretty quickly here for everyone 100% across the board. I spend a significant amount of my time working with chief information security officers and IT security folks from other institutions
make them feel better about our systems outside of NEMSIS in NEMSIS. And one of the things that we do offer as a service is for us to have those conversations with your state security office or whoever's in charge of that. And so please give me a call if we can ever provide that service. We could explain. I'm confident that if we had the time to explain what this was and that it was multi-factor authentication and why it needed to be installed, and Okta is kind of the gold standard for this. I think we'll find that the federal government is actually going to adopt Okta for many of their systems. I think we could probably alleviate any of those concerns. So thanks for that comment from Texas. Any other questions and concerns, comments? Hey, Karen. Oh no, this is scary.
Right?
This is
should
scary.
be. It should be. Good to see everybody. Great DCC, NEMSIS, IT crew over there. So glad you guys were all able to come today. First of all, before I ask my question or bring up an issue, are you done with your presentation? Because if you want to continue.
No, we've got a few minutes.
Okay.
We've got a few minutes.
So my question has to do with reporting and what's happening in the database. So I currently have the public cube open. And so let me start by asking, is the cube as it exists today, is that going to be maintained, or are you going to move to a BI tool?
We're going to maintain it in the cube for now.
Okay.
I mean, I don't know of any other plans.
So at this time, the new NEMSIS version 3.5 elements are not in the system.
That's right.
So what is the time frame for implementation of those?
Christine, is that by the end of the year? Yep. Probably before, but no later than by the end of the year.
Okay. I think it would be beneficial if that went out through a Google group. I was pulling some data on behalf of South Dakota, and I was just using the public reporting database. And for those, and I love the cube. You guys know that. I love the cube. It's fantastic. But for example, when you get, so you want to start looking at version 3.4, incident patient disposition, there is now a value in there that's called not reported. And so, and it's a blank, right? Because that's a mandatory field. So the data, it looks to me as if the data is still going in the cube, but for all the new disposition values that are not in there, it's just falling under that. So you just have to be careful. And subsequently with the Tableau dashboards, I know there's a handful that used incident disposition, and wondering what the plan is to update those. So and I know that's a combination of to UIT and, well, it is you guys, right? Because you're doing Tableau.
Yeah, no, those are great observations. Thanks, Karen. Yeah, so I think, what's the timeline, Alex? No pressure, but when are you going to be done with that? We just talked about it a couple weeks ago. Okay, by the end of the year, no later than. Thank you. You're welcome. It's literally Alex here that's going to do it. So we'll give you his name and number. Please feel free to contact him if you need anything at all. All right. Okay, so next steps and future initiatives. I mean, I think this next year and every year in the future will be exciting. We're going to continue to target continuous improvement. We're going to be looking to adopt different technologies in AWS. We're going to continue to deepen our knowledge and depth of our knowledge in AWS, which is very different than running an on-premises data center. I'm personally excited about the agency level reports in Tableau that we'll be working on. We're going to start development on V351. We're going to continue to develop skill sets to create new tools that that are going to be helpful for you. And I'd like to end by just saying, I'd love to hear from you directly. So if there's anything that I can help you with, any concerns, challenges, in particular with the AWS migration, please feel free to reach out to me. Clay and team can give you my contact information. Okay. Thanks very much.
A little bit earlier than the agenda, just to make sure people have time to change their clothes or prepare for us to be able to head up the mountainside. Looks like the weather's going to cooperate, so I'm incredibly excited. There's lots of great rides up there that you won't experience anywhere else, so that'll be a good stress reliever. I was scheduled to talk about something that Lisa mentioned, that is we're charged with developing agency-level reporting using the national data set, which I'm excited to do, but I want to spend some time to make sure that we can augment, support, work in parallel with vendor reports that are being made available to agencies or state-level reports, right? I don't want mine to show different or ours to show different values than yours, or for ours to just be the same information. So we have to work out where we can be most valuable. I can spend 30 minutes talking about that, getting your feedback, or we can try to finish the requests that have been made for version 3.5.1. So I'll just call it to a vote. How many want to try to finish all of the items that have been prepared for us to discuss in regards to revisions to 3.5.1? Raise your hand. Hold them high. Okay. Those who would like to delve in a little bit into agency reports and begin to figure that process out. Oh, wow. You guys make this freaking hard. Do I need to add them? What? It's always 50-50 with this group. Yes. Yeah, we'll do that on a weekly call. So we can cover that on a weekly call, collect information, or we can try to get through the comments. I kind of feel like it's easier to go through the comments here rather than on a call. So I would prefer that, but I think I've already drained your goodwill to the. I think I've already drained your goodwill to the very end. So. Yeah. Well, it's after lunchtime now. End of conference. Okay. Jen? Let's do it, guys. Let's do it. I want to make sure you're getting your money's worth. So Jen, how many more do we have? We have 10. 10. Only 10.
Does anybody need the QR code?
Yeah, QR code again. Let's get.
Sorry, does anybody need the QR code again? Yep. All right.
Let's get it up. Thank you very much, folks. Thank you. If we can get through this in 25 minutes, and it should be easy to do that.
All right. So last round, the QR code is up. Please get your phones up or use the URL. Oh, presentation mode. I absolutely can. You are welcome. I'll give everybody just a minute. All right. Anybody else need more time to get the QR code or the, there's one, hang on. Thumbs up? Yep, thumbs up. All right. So we are going to not go through 123 slides that way. 133. All right. Those were the results from the last poll that we took. And that brings us to Survey 3, Question 6. Add a new element for stroke scale score in the eVitals stroke scale group. So this would be a numeric value for things like your FAST-ED that has a numeric value, not the positive, negative, or inconclusive that is already collected. So this would be in conjunction with eVitals 29 and eVitals 30. State data managers' comments were auto-calculated similar to GCS would be great. Consider renaming eVitals 29 to stroke scale result. Won't be used by states or agencies that don't use stroke assessments with a numeric value. Vendors, they will do the assessment in the hospital anyway, and there's no need to waste time on that information in the field. Not all stroke scales have scores that could use this field. This would not do away with the positive, negative, or inconclusive. That would still be available as well. Multiple scale scores could be utilized. Not sure vital signs is the right place, a separate section or the mental assessment section for strokes. Other commenters support the idea, may need more refinement. Any questions or comments?
Was this request, I think we've had the request in the past that there's a stroke score. Do they show the signs or not show the signs of a stroke? And then there's stroke severity scores, right? So how does this request vary from what we have now in NEMSIS? Is it that they want two different scales? One's that, was it a stroke, and then one for a severity?
Right, so the one we have now, it asks you to answer positive,
yes,
negative, or inconclusive. So it just says, is there stroke symptoms present, kind of thing. And this one is asking for a numeric value from the different established stroke scale scoring assessments. I'm trying to be careful how I say it. So like you could get, and I have them on my desktop on my computer, like you can have one that goes all the way up, I think it's like 30, and one that goes down to like a -2.
Right, so add numeric here.
So it would be numeric. So are there any questions, concerns, or comments? All right, let's go ahead and, oh wait, we've got one.
This is Hannah from Montana. I think that this is a good idea, but I think it's more important to also separate out the stroke, presence of a stroke assessment versus the severity scores. It's difficult. It'll be difficult to document clearly while all of those types are still in eVitals 30. They're all like mushed together, and you can't tell which one is a assessment and which is a score.
So you're saying it maybe consider separating the ones that would have a numeric value, a score value, versus the assessment for present or not present kind of thing.
Well, they're not all, like the presence of a stroke assessment sometimes have numeric, but I think clinically, like having them all mushed together in one element gets confusing for people.
Josh?
This is Josh Legler. One thing I've seen in real world data, especially a couple of years ago, was that EMS providers using a particular software system were doing a very comprehensive kind of stroke assessment. They were using one of these tools and they were getting a numeric score or something like that. And then when the data got exported, what the state received was just a blank for the positive negative score. So, from that perspective, it seems like it'd be nice to have a place for them to actually export that higher level of detail that they did in fact record on the scene, and be able to send that to the state. On the other hand, I think if I understand what Hannah's saying, each of these is a little different, right? Some of them give you a numeric value and some of them don't. And so, from that perspective, maybe some more work is needed to figure out how to broadly support all of these different stroke scales. I don't know.
And John Pringle from Water. Yeah, I totally agree with that. I can think of at least 4 or 5 different type of stroke scales offhand, whether it's Cincinnati, Los Angeles, the sky is blue in San Diego, and how those are dealt with is very regional almost sometimes in niche. And so just to try and fit them all into one numeric value is probably not going to work for many of them. I think more work or some other semblance on allowing, like Josh says, different varieties of strokes so those regional operations can use them, and maybe not pushing them all the way up to the national level would be better.
Okay, Ridgely, Massachusetts.
Hi, Ridgely from Massachusetts. We have a custom element for this, and it was kind of confusing getting it implemented. So, it'd be great if it was something that was standardized across the board. And I know a couple other states are using it. Can you not hear me? And I guess I would just say that, you know, if you have a number for your stroke type scale, then this works, and if not, then you don't, and then that's something maybe we add at a later date. So I wholeheartedly.
Andrea?
Yeah, I agree. So like the stroke scale score can be just the score, like the population of that score, and then documenting the type, like the stroke scale type that was used to come up with the score is a different data element.
Yeah, that would not be going away. You would still say which type of stroke scale type you had. You would still be able to utilize inconclusive, negative, or positive if that's the result of the score assessment that you used or a numeric value. So those would all, that was the request as it is. If you think it needs more work, more refinement before it gets added, that is absolutely a legitimate choice on the selection. And are there any other comments? All right, let's vote. Yes, needs more work. No. All right, 5, 4, 3, 2, 1. Everybody in. Survey 3, question 7, add a new element for Richmond agitation sedation score in the eVitals section. It would be an optional or recommended element. State data managers that said no said there's a way to capture this for, there are ways to capture this for agencies that use it. The ones that said yes should be calculated automatically. Some states use bars, and it would be good to have options. The current should be 0 to 1 per grid, but 0 to many per ePCR. That's a technical one. Consider adding other options than an integer. Vendors haven't had any customers request this. Has this been adopted for an EMS national standard? EMS provider agencies, no, these should be included in the complaint section. Yes, build a form, but would be good to have as long as it is optional. And other, supportive but needs more refinement. Any comments, questions, or concerns in the room or online? All right, seeing none, let's vote. Yes, as is. Yes, add other agitation scale choices, needs more work, and no. All right. 5, 4, 3, 2, 1. Everybody's. All right. Survey 3, question 8, add a new element for e-exam PTA time. This is a new optional or recommended element. It would be treated kind of like it is in the procedures and medications prior to arrival for e-exam. The state data managers that said no said do not see this as a benefit, could be used in lieu of doing their own exam. Structure of NEMSIS may make it difficult for a unit crew to document another EMS clinician's exam. Yes, this causes issues all the time. Vendors as part of the e-assessment group, then yes, crews will do it anyway, no need for this. EMS provider agencies, no, that voted no. The definition of an exam is what the EMS clinician sees, not what someone else saw. No need to add this documentation to EMS clinicians. The ones who said yes said very important. Other, not sure why the crew would document an exam not done under their care. Questions, concerns, or comments in the room or online?
Samantha from ESO. We have had requests for this, specifically in the context of, you know, first responder on scene, they start patient care, they start the assessment specifically, and then the transporting unit gets on, they transfer that information over, and then the transporting unit and the hospital don't get that initial assessment data, so we would be completely in favor of this.
Any other questions, concerns, or comments? Andrea?
My question would be like, if they're documenting an e-exam that was done, wouldn't the timestamp for the e-exam indicate that it was before the time of arrival?
It could, but I believe the timestamp is not required.
Okay.
It fails validation at the NEMSIS national level. If you have a assessment time before the at patient time, there are validation rules that get caught in the schematron, either at the national or the state level, saying that this is out of sequence.
I would think.
Just want to clarify that those are not national rules because these are not national elements. But there are rules in existence.
There are rules in existence.
I would just hesitate to create another survey, another data element for something that can be calculated with a date timestamp. If you were to expand the ability to put in a time that was before your time of arrival, I think that would be more than enough to indicate this for others, or indicate this for the, like, looking at the data, instead of making a new element for it.
Any others? Let's go ahead. Oh, wait, there's one from online.
Online, Jason Lefebvre from Action Ambulance indicates that it can be documented in the narrative when they receive a report from first responders.
All right, let's go ahead and vote. Oh, wait, hold on. Carissa?
From Zoll. This is the one thing that I'd probably also support putting into the, I'd put this in that software as well. I think we hear the same thing that ESO hears, the hospitals don't get that complete record, so.
All right, let's go ahead and vote. Get your votes in. 5, 4, 3, 2, 1. All right, survey 3, question 9, adjust the e-patient 13 gender element title. The request was to change the title to gender identity. If you can pull up e-patient 13. All right, state data managers say no, unnecessary, no clinical significance. There are medical conditions where it's integral to know gender. Gender and identity may need to be kept separate. Yes, consider aligning more closely with US CDI, adding this as an issue of respect for an individual. EMS provider agencies, no, not an EMS issue. Our treatment makes knowing biological gender a requirement. Yes, the ones who voted yes, but adds complexity to gender-based validation rules. Other needs refinement. Any questions, comments, or concerns? Maura?
I think this is complicated by the fact that gender is, or e-patient 13 gender currently is combining both gender and biological sex, which I know we covered earlier, but I think this supports that maybe it should be separated.
Jen? To clarify, is this...
Keenan from Zoll?
To clarify, is this just changing the title from gender to gender identity?
This request is just changing the title from gender to gender identity. Hannah?
I think since there's been so many different proposals on this topic, it warrants like them all being looked at together as one conglomeration.
Anything else? Okay, so there are a couple more about gender, so that's actually a really good idea that they might need to be all taken together. Let's go ahead and vote. All right, 5, 4, 3, 2, 1. So this one is for Survey 3, question 10, was adjusting the e-patient 13 gender element definition, right? So we just talked about the title, going from gender to gender identity. And this one was a request to change the definition. The current definition is the patient's gender. The suggested definition is the patient's internal sense of being a man, woman, both, or neither. The comments summarized by the state data managers, current values and definitions are sufficient. There are medical conditions where it's integral to know gender. Gender and identity may need to be kept separate. A change is needed, but we can't rule out biological sex. There was that question about sex at birth. Maybe better to add a new element rather than change the existing element. Vendors, new definition would be clearer and less charged if you use the word identifies instead of internal sense. Clarification of values available is needed. Irrelevant in medical treatment, not an EMS issue, and needs clarification and refinement. So if you think this all needs more work on how they're all going to go together, needs more work as a perfectly viable option. Any additional comments, questions, or concerns? Eric?
Jen, it's my intention for this element to track as closely or verbatim with CMS as possible, for the sole purpose that anything CMS does or anything that we do would impact billing, ONC would have this requirement with CMS, and US CDI, how many acronyms can I do together? That's pretty cool. The US CDI would include data specific for CMS as related to gender. And I know at NEMSIS there was some talk about Clay dragging his feet on this particular element, and that's not the case. It's absolutely me. My goal was to either align it with OMB in the federal requirements that they had for personnel, or to align it with CMS. CMS is my first choice, and I would hope that they would be aligned, but it is the federal government, and I can't guarantee that.
So I say, let's vote. I'll give you just a few more seconds. All right, let's go to Survey 3, question 11. This is another gender element, allowed value descriptions and adding attributes. This is the last one. No, there's 2 more. We're almost there. This is the last one for gender. No, there's 1 more for gender. There was the request to add attributes of refused and unable to complete for e-patient 13, which is the gender. Deprecate the existing values of female to male, transgender, male to female, transgender, other, neither exclusively male nor female, and add in prefer not to answer. We're not sure how that's different from current, the refused. Non-binary, gender queer, non-exclusively male or female, questioning unsure, and don't understand what this question is asking. And the summarization of the comments that were made was gender is biological, no clinical significance, gender at birth needs to be known, keep the deprecated values and add the new descriptions. Verbiage is important. Those who voted yes, it should be noted, could be very sensitive. And again, we've got what Eric said about aligning with the CMS values, so we got to keep that in mind as well. Vendor said more clarification is needed, open to adding them, but need to know more about the gender values. EMS provider agency says not an EMS issue, too vague. Gender queer doesn't seem to fit. Other, can we review all the changes together for e-patient 13, which is exactly what Hannah from Montana suggested, and we're going to go ahead and vote. And we're getting super close to time. We're almost there. All right. 3, 2, 1. All right, this is the last one in regards to gender. It was a request made to add a new optional or recommended element for transgender experience. The state data manager said no, not needed for EMS care, kind of along the lines of the same things that we've said already on them. This might be another one that has to be looked at when we look at all the other gender items that have come up. So we can go ahead and vote unless there is anybody who wants to say, all right. And after this is the last one. I know you're all very disappointed. I will miss this when I go home. All right, let's move on. Survey 3, question 13, add a value for other race to E patient 14 patient race. State data manager says other race is same as unknown, but it may help providers when they don't want to say specifically. Vendors consider for D personnel 13 as well in EMS personnel's race. The addition of the pertinent negative values resolves this issue. That was one that was approved at over 90%, so it's moving forward. It's the same as the custom element, the national custom element, what that was developed, adding refused, unable to complete, and unresponsive. Thank you, Peter. So that was added. So those pertinent negatives will be in 351. So if you think you need other race as well. Any comments, questions, or concerns? We've got Kevin.
I can't recall whether I read it in a federal register or whether it was in state law, but there was specific language that other should not be used, that it was removed and it should not be used. It should be unknown or something else, but other should not be used.
I agree. And a bunch of the standards where other is being removed, well, other hasn't existed there, and I really encourage the use of unknown. I'm not sure if unknown is a part of a pertinent negative or not, but none of the pertinent negatives have an unknown in it. But it definitely should be an option that you can put in because there's a lot of discussion around letting people say, I don't know, versus guessing. Because the race ethnicity should be patient reported. So if you're unable to get that, then you can have that easy unknown so you can move forward with the documentation.
Perfect. Let's go ahead and vote because we are at time. Oh, sorry. Go ahead, Brooke.
Oh, I was just going to say that I think unknown is sufficient. We already have trouble getting this element documented accurately by providers anyway. We actually have providers that will list all of them. So if we give them other, I think it's just another bucket of if I don't want to get it, I'm just going to throw it into there. So I think that just muddies it up even more.
Thank you. Oh, go ahead, Mara. Everybody can just keep voting.
Is this a field where you can select more than one?
Yes.
Okay.
Yes.
All right. I would just like to say thank you to everybody for your patience and your continued attention on this. And we are done with them.
Great, thank you. Okay, well, give yourself a hand. We went through every single one of the. Any questions related to that? Any other final comments? Was this a good conference? Did folks enjoy their time here? Okay, thank you. And to Monet, to the NEMSIS TAC team, thank for all the work that they did to make sure that we had an experience here that flowed smoothly and efficiently, and we got a lot done. Thank you so much. We'll see you at